Right, good morning, everybody. Good morning. We haven't started, have we started live streaming yet, guys? We have, okay, thank you very much. And welcome everybody to the Integrated Care Board meeting for the, hopefully, 26th of March. Lovely to see you all. Just a reminder that we are live streaming. And that we're either in or about to enter into the pre-election period. First of all, some new members. Let's see who we've got. Have we got Moira with us? Oh, hello, Moira. Yes, welcome, Moira. First meeting as a full board member and replacing Pete Devlin. We have Craig, you've joined us, Craig Rivet has joined us at the back of the room there. Welcome, Craig, as new co-chair of the Integrated Care Partnership and chair of the Health and Wellbeing Board in Suffolk, and replacing Andrew Reid here today. Lovely to see you. And I think before we go to apologies, let's do some thanks. I've already mentioned Pete Devlin, so we should say thank you to Pete for all the work he did for us on behalf of Essex County Council, and obviously we look forward to Moira's input. Now, Jo, have we got Jo Mail with us this morning? No, she's not here. So Jo's last meeting would have been today if she'd been with us. So I think, again, we'd all say thank you to Jo for all the great work and support that she's provided to the Integrated Care Board and all the other parts of the system, if you like, over many years. So thank you to Jo for all the great work, and good luck for best wishes and good luck for her new future. And Jeff, I think also your last meeting today, so thank you for everything that you've done for us. And Jeff has also chaired finance and estates, been a member of finance and estates and chaired audit. Oh, the other way round. Sorry, have I got my mind the other way around? Thank you. Chaired finance and estates and member of audit. So thank you for everything you've done. Jeff has been Much appreciated. Thank you. In which case, let's then go on to apologies. And Tom, I'm going to come to you for that, please.
Thank you, Chair. I've received apologies from Caroline Donovan, Laura Taylor-Green, Paul Jabara, Ewan Cameron and Councillor John Spence.
Okay, and for Ewan we have Craig, so welcome to the meeting. And for Caroline we've got Kath, so thank you for filling those places. Now, questions from the public. Mr. Dooley, who's in the audience, has sent in 7 questions, and had a chat with Mr. Dooley before the meeting. Do say, Mr. Dooley, if this isn't your understanding, but questions 4, 5, 6 and 7 are not concerning agenda items, so we're going to give a written response to those. And questions 1, 2 and 3 refer to agenda items 7, 8 and 9, and we'll deal with them. Simon's going to read the questions out on your behalf when we get to those agenda items, and then we'll answer them in the meeting. Conflict of interest with any agenda item other than those of which we're aware? And no, I think is the answer to that. Thanks, everybody. In which case, minutes of the last meeting, the 30th of January 2024, of which there are 10 pages. There's a couple of typos which Tom is going to correct. One is the spelling of Vivian Yu's name and the spelling of Andrew Reed's name. But other than the typos, are there any other issues regarding accuracy in the minutes? No, nobody's got anything to raise. Should we therefore say that the board this morning received the draft minutes of the 30th of January 2024, and other than a couple of typos, approved that draft as a true and accurate record of the last meeting? Agreed? Lovely. Thanks, everybody. Then moving on to the matters arising in the action log. Now, as far as I could tell, all the actions were either complete or on the agenda, with the exception of item 2406 on virtual wards. And I'm going to go to Andrew to give an update on that item, please.
Yeah, of course. This didn't quite make it through in the presentation last time we met, but the virtual ward programme is already fairly strongly embedded across the system, not just in West Suffolk Hospital, but also in Ipswich Hospital and Colchester Hospitals, and already reports into the Urgent Emergency Care Committee of the ICB. So I think we can regard this action as closed with that reporting structure in place.
Everybody happy with that? Yeah. And were there, with regard to the matters arising that I've said were closed or on the agenda, anybody got any issues with that, or are you happy with that? And are there any other matters arising or actions that should have come out of the 30th of January meeting which we didn't capture in the log? Otherwise, we'll say that the action log is complete. Good. Yeah. Thank you for reminding me, Mr. Dooley. Yes, so at the previous meeting, Mr. Dooley raised questions, 2 of which the written answers haven't reached him, but we have discussed that this morning, and they're on the way to him. So do let me know if you don't receive them, won't you, Mr. Dooley? Okay, good. And if that, unless anybody is raising any other issues, I'm going to move us on to the next item, which is the CEO's update. Ed, over to you.
Thank you, Chair. I mean, just a reflection from last week's meeting. I thought it was really fantastic to see the commitment to collaboration around the new elective orthopaedic centre. Some really positive press coverage, and I think a great result in train for the community. So really delighted with that. A few things I just wanted to pick out. Firstly, just to reference the ongoing progress, I think, at the East of England Ambulance Trust, and of course we're the commissioner there. Year-on-year improvements, virtually all of their metrics in terms of response times. They've seen a 10% increase in vehicles over the last year, reduction in the sickness and in turnover, and some really excellent work in terms of integration with community services across the 6 ICB areas. I think what's been really fundamental has been reduction in ambulance handovers, particularly in the Norfolk and Waveney system. And I just wanted to thank Nick for his work as Chief Executive in Norfolk and Norwich, and the difference that he made there in terms of safety and quality in patient care. So thank you, Nick, for everything you've done, and great to have you back. We have on the agenda today our dental plan, which we're really pleased to receive. We'll go into it later, but we're already demonstrating improvements in access, and we'll accelerate those further. However, there has been coverage in the East Anglian Daily Times overnight from Toothless in Suffolk campaign group, who feel that the plan doesn't go further enough, or further and fast enough, and they don't feel sufficiently listened to. So I think my commitment, our commitment, would be we'd be delighted to meet with Toothless in Suffolk. Any plan is there to be improved and to be developed. So we've absolutely open door to that conversation. I know Peter will echo that message when we get to that item. We're absolutely in the thick of the planning round at the moment, as is all of the NHS. We are in a position where we're compliant in a number of areas now with our plan. The main area now is around our finances and getting to a balanced plan, so more work to do there. We're also in the thick of, obviously, delivery of the year-end position. In particular, we have the 76% A&E performance standard to be delivered in March. Without wishing to jinx anything, we're in a position where it's possible to deliver it by the month end, if we can keep sustaining the performance, and hopefully put us into a better trajectory going into 24-25. The NHS staff survey has been published just recently. For the ICB, we came out in the top 5, which was an improvement. Unlike many ICBs, we haven't seen a drop in our staff survey, which is good in a year where we've been tackling our running costs. So I think that's an encouraging sign, and we've just completed our consultation process, and we're supporting, I think, around 13 individuals to secure employment and hopefully avoid any compulsory redundancy. I'm sure Susanna will touch upon this, but there's been a number of really great events in the system around culture and inequalities. We held a cultural safety event, which was organised by Tanvir Alam, who's a GP in North East Essex, Assistant Medical Director here, which was the first of its type nationally, and it's been looked to be rolled out nationally, so we're delighted to host that. Secondly, an excellent event with the Voluntary Sector Assembly. Cohort in our community to really understand the lived experience of looked after children better, and to think about what more we could do. One of the things I took away from that is that the term system, which we use in a really positive way, don't generally integrated care systems and system this, system that, can have very negative connotations for looked after children, where often people have had a very bad experience of going through a system and feel chewed up and spat out at times. So
it was really, really helpful to think about our language and checking our language and thinking about how we go above and beyond, I think is your term, Susanna, for our looked after children. And equally, Susanna's been organising a set of uncomfortable truth sessions. We've had 2 so far, a third one to come, and that's the debate there, and I think the commitment of system partners there has also been very strong. Final thing I just wanted to touch upon was a couple of awards. So our LMNS around maternity has achieved a regional award for the work they've been doing, and there's been some fantastic work in the kind of terms of equity and in terms of reducing smoking in pregnancy. And the Woodbridge PCN and supported by the ICA have won had a silver award at the HSJ National Awards for their work around falls and population health management, which was great to see. So congratulations to them. And then finally, I've become involved in work around coastal communities nationally. We commissioned a report with NHS England called Turning the Tide, which is setting out the issue of inequalities in coastal communities and some of the actions that could be taken to address those issues. And we've particularly drawn inspiration in that report from some of the work in Clacton and in tendering around employment and community diagnostic centre, of use of the voluntary sector, all manner of interventions really there. So it's great to see tendering setting a bit of an example nationally there. So thank you, Chair.
Ed, thank you very, very much. Some really great work, and thanks to all. It's a team game, isn't it? So thanks, I'm sure, from board members to all colleagues who've worked hard on delivery so far, noting that there's still an awful lot to do, of course. Any questions at all for Ed on the CEO's report or anything relevant to it? No, in which case received and noted with those supportive comments, Tom, if you would be so kind, from board members. In which case, let's go on to item 7, which is the item on that's so important to everybody, of course, on improving oral health in Suffolk and North East Essex, the ICB Dental Plan. Now, Peter, I'm going to come to you, but we are 5 minutes ahead. So no pressure, but you've got to keep us 5 minutes ahead, because that 5 minutes could be the coffee break that is not built into the agenda. So keep us to time.
Okay, message received. Thanks, Chair. And really pleased to welcome Nick Barker to the table as well. And we're going to give a joint presentation, and Nick can introduce himself shortly. Obviously, this is a really important day for us, I think, as the Integrated Care Board. We picked up responsibility for oral health commissioning last April, and this plan represents a combination of lots of work that we've done with partners, and particularly the team led by Greg Brown. And we're really interested to hear feedback from the board, and we hope this sets us well for the future. So Nick and I are going to take us through the slides. So we thought we'd perhaps speak for about 25 minutes, 30 minutes, that's okay, to colour in the plan a bit. And then we're really pleased to develop that further. So hand over to Nick.
Yes, thank you very much, Peter. Morning, everybody. I'm Nick Barker. I'm what is about to become the co-regional chief dental officer alongside a colleague of mine, Tom Norfolk. That position starts as from the 1st of April. We're currently the local dental network chairs, so our position carries on, and I'll talk somewhat to the structure in a short while later in the slides. I'm also actually the Deputy Chief Dental Officer for England and Professor of Oral Health Sciences at the University of Essex, and a programme lead in the Master's course of Periodontology at the same university, so notes for declarations of interest. So as to our talking to the situation over poor oral health, we have a significant issue, and if I may, I'll share Peter's slides, which may be easiest. So we have a situation that is broadening as to health inequalities related to oral health. In part, that is related to the way NHS services have historically be contracted. What we do know is that the two major dental diseases are tooth decay and gum disease. Both are non-communicable diseases, and in actual fact, gum disease is the 6th most prevalent disease in the world. They both react well to prevention and can be achieved. So what we're really looking to do is find some treatments for those health inequalities and move on from there. So Peter, if I can have the next slide. So children's oral health is generally strong in Suffolk, as we've stated, but there are deprived populations, and this is some of the issues that we have in that poor oral health is directly related to low socioeconomic groups, and we do find that the tooth decay is the #1 reason for young children to be admitted into hospital to undergo general anaesthetic. Again, I emphasise the fact that this is on something that is a preventable disease and something that we need to move alongside. Adults' oral health, similarly, there are strengths and weaknesses, and across evidence of active decay, you'll note on the slide that certainly in Essex there's a higher level of active decay within teeth. Fortunately, the oral cancer rates across SNE are lower than average. But on the right-hand side of the slide, the key element to note, as far as the Integrated Care Board is concerned, is that if we're going to use prevention of these diseases as a key element to improve things, by preventing the diseases, it has a bi-directional effect, and there's a very strong evidence base to this, such that, for example, poor diabetic health is if we improve oral health, the same for cardiovascular disease, dementia, low birth weight babies, etc. This is all because these have inflammatory markers. Oral health has a high level of inflammatory markers within the bloodstream, and therefore other diseases can be directly affected. Thanks, Peter. Thank you. My eyesight's not that good, so I'll move over to Peter for this one.
Yep, we just wanted to include this slide just to illustrate and just remind everyone that the NHS dental care is not free at the point of use for the majority of the population, and there's also a strong private market, and so that in terms of people's access to dental health, that drives inequalities between populations. But it also, for the working population of the dental workforce, they have a really active choice between working in an NHS setting or working in a private setting. But I just wanted to remind everybody we are dealing with something slightly separate in terms of what we're used to dealing with in our normal NHS commissioning environment. These graphs give an indication about the amount of people who are able to access NHS dental services. And the graph on the left shows the percentage of the population who've accessed a dentist in the last 24 months. And that was at 38.7% of our SNE population had been accessing NHS services. And that shows a reduction from 51% pre-COVID. And so COVID definitely had a massive access impact, and dentists are catching up on those contacts with our residents. On the right-hand side, you can also see measures of the courses of treatment that are being completed and the units of dental activity. And I'm pleased to say that if you take the percentage of population that's have accessed NHS service, it's gone up from 38.7% to 42% by by October 23. So we are seeing a rapid increase in the amount of NHS access, but it's still below that 51% that was the pre-COVID statistic. But again, important to demonstrate that we're not necessarily providing a universal service in terms of everybody looking to the NHS for their dental care. This next slide just illustrates the contracted activity that we have in place. And Nick will talk in a moment about the sort of impacts of the contracts for the dental providers. And what you have here identifies the number of providers that we have in place and the units of dental activity, which is essentially one dental health check counts as one unit of dental activity. And there are different bandings of work done by dentists that count as more than one UDA. And you can see that across SNE for 22-23, only 74% of the contracted activity was delivered. 26% wasn't. So we've got contracts out there, but the dental practices aren't able to generate the UDAs in the way that enables them to receive income. And we'll talk much more about the nature of the contract. We also know, with regards to the experience of the wider NHS, that this is a major reason for people calling NHS 111, the 2,000 contacts a month, and that could be people trying to find a routine dental access point or with an urgent dental problem. And we'll hear from Health Watch colleagues a bit more about that later on, where people are trying to get urgent dental access and not able to, and using 111 as their main reason for main route in. And we're also seeing presentations in A&E and in GP practices because the dental system isn't functioning as it could and should be doing. So from a patient point of view, this has significant impacts, also from their wider well-being and general economics. Thanks.
Thank you. So why has it worsened? Well, the background is going back to what we've shown in the last few slides. A key element was the way the contract worked. The contract came in 2006. By 2009, following a report called the Steele Report, it was declared unfit for purpose. There's been various reviews back to those original points, and indeed last year there was a Health Select Committee that met over 2 sessions, receiving evidence from various experts. I have to declare I was one of the experts involved in that, and there was a report released in the middle of last year that again reiterated the fact that we actually need innovation and reform of the contract, and there has been a further review only last week, again over 2 sessions, which came to a similar point. So the issue is, as the slide talks about, is that the current system, the unit of dental activity, is the only measure that we have in the current contract, which says if you come to a dentist and you have something done, that earns a unit of dental activity, a widget. So it's all about performance. So it's driving teams to perform dental services rather than work under what might be termed best practice. The unit of dental activity is effective for patients who are regular attenders, who come in and they just churn good oral health. We can tick off a widget, it's easy to do, but if you've got somebody who turns up who needs 10 fillings, several extractions, a new denture, etc., then the current contract of earning widgets is nowhere near so good. I.e., if you have 1 filling done, you earn 3 UDAs. If you have 10 fillings done, you get 5 UDAs. And yet it's taking multiple more times to do it. So this is where we're looking at. The other issue is that the contracts are, in the main, long-term contracts. GDS is an in perpetuity contract, a general dental services contract. So those contracts continue until either the practice chooses to offer to hand the monies back, or the ICB can organise how exactly that may be procured elsewhere. The good news is that that is now under a change, and that the ICB has greater strength to take back long-term underperforming contracts and turn it to somewhere else. On the right-hand slide, we've seen the fact that we know that the people performing dental services are reducing. Particularly the younger generations are turning away from NHS dentistry to at least an extent, where they're only performing part-time and reduced hours. Thanks, Peter. But there are opportunities. We've had various elements come in, particularly some guidance that came in last year from NHS England Central Office that talked about the ability to flex contracts. So this is moving away from the unit of dental activity into a different model. and we can start to use that. And originally it was said it was 10%. The new commissioning contract says it would normally be around 20%, but it can go upwards of 20% as well. And what we really want to do is use something whereby and other elements that suit other groups, both working inside of a practice and in outreach services. Further, there's also guidance that says historically it's only been the dentist that could run a course of treatment. You could get other dental care professionals. This is the dental nurses, particularly upskilled dental nurses, something like a nurse practitioner. We have hygienists who carry out treatments for gums, and therapists who carry out a wide range of dental treatments, nearly that to the dentists, other than the ability to provide laboratory items such as crowns and bridges and dentures and carry out root fillings. So we've got new guidance that says we can utilise these. If you take that alongside the flexing of contracts, then all of a sudden you have a much larger workforce who are actually able to provide further care. Peter, over to you.
This is these, Tom.
Sorry. I'm a slide ahead of myself. Apologies, sorry. So we've also got other challenges across, rather than just primary care. In secondary care, there are reduced training numbers. We have consultant vacancies. There are limited regional specialties. So we're moving away. And also getting hospitals to work together in acute trust form has been historically quite challenging, both within the hospital as well, between different specialties, particularly medical specialties as well as dental specialties such as head and neck cancers, and then across acute trusts where there might be a hub and spoke model where one has a particular housing for something like oral surgery and another has a housing for orthodontic services. So what there is a specialism in primary care as well. We have the ability to use level 2 contracts. This is something like a dentist with enhanced skills or a special interest, as has been used in the medical models as well. This is somebody's sub-specialism, but that is actually recognised as having sufficient skills that they can undertake more complex work. And there's an opportunity to develop that across many dental specialties, particularly in root fillings, gum treatment, special care dentistry, treatment of children, and the like. So we have an opportunity there, and likewise, we're looking to reduce orthodontic waiting lists through the specialists in primary care as well. And there's also currently a review involving Health Watch, particularly in Herts and West Essex, and learning from that to share with the SNE ICB. Thanks, Peter.
So I think what we've done is we've set out what is a slightly grim, but ultimately let's be realistic, situation that we have of what current dental access is like and all the challenges that are in front of us. And we really wanted the board to sort of, as much as possible, immerse yourselves in what the challenges are. And so we're now going to talk about the strategy and what our approach to this is, and really wanting to emphasise that if we're going to make an impact, like lots of aspects of our work as health commissioners, we have to work across the entirety of the oral health continuum, from the great promotion of the right eating habits in preventative terms through to the most specialist care. And we've set out a series of principles that we want to use to guide our strategic approach. And we've not mentioned them so far, but the educational institutions, the universities and colleges are really important in helping us to develop the future dental workforce. And as you know, there's lots of great innovation we'll come on to in a moment. And so that partnership with our universities, our practices, and a preventative whole body approach is what we're looking to take in how we progress with our strategy. This needs it is as a team game, to use some of your phrases, Chair. And so we're fortunate we have our two regional dental chief officers sharing the lead role. Just the next slide, sorry. We've recruited 4 senior fellows and mid-career dentists who are supporting us and our neighbours in Mid and South and North and Waveney ICBs. We've increased our team because there's so much work to do here, and we're taking a multidisciplinary approach and working closely with the public health consultant at regional level to look at what our health needs are using their advice. And so we've set out a 9-point programme which we'll give you the headlines of in the next 10 minutes as we take you through what our proposed approach is. If I do one more, then I'll hand back. So back on prevention then. So what's the first aspect of our plan is, as we talked about, is the prevention approach. What we've done with, and I've tried to do with this document, is to give you specific dates that we're holding ourselves to account for certain review dates or certain new services going live, and who the lead organisation is. And there's lots of detail behind this that we have as a work programme that we're looking to with regards to our prevention. But our prevention programme so far involves going into schools, and we've worked with Suffolk County Council and with Essex County Council and taken similar but slightly different directions based on where our conversations have taken us. And just taking Suffolk County Council, we've got a mobile resource that is going into targeted children and family groups and for homeless centres, and we're expecting to have 1,400 assessments per year in those situations where people might not otherwise be getting their dental health assessed. In the North East Essex side, we've done some important work with care homes of training staff to help them understand dental oral health and be skilled to do so. And we've got 6 homes already trained, and we're looking to increase that through this programme and many other initiatives. That's just some of our examples. So perhaps, Nick, I'll go to you to talk about the workforce.
Yes, thank you. So, as Peter's pointed out, we've got some university input. One of the larger issues that we have in east of England is we don't actually have a dental school somewhere which is training undergraduate dentists, but we do have 2 centres now, the University of Essex and University of Suffolk, both of whom are training hygienists and therapists. In fact, University of Essex has the largest cohort of undergraduate hygienists and therapists in the country. So there's an important element there that we can start tapping into. We can look to develop centres for dental development. This was a term developed by the Advancing Dental Care, a national report by, as was Health Education England, which looks at sharing that care across a wider team. And we have aspirations as things such as advanced clinical practitioners, which is something that's in normal medical care, but in dental care we haven't developed that as yet. And yet we have opportunities in vis-a-vis apprenticeships for across various levels. So advanced clinical practitioner is at a master's level, but at an undergraduate level, University of Suffolk are already looking at a level 4 qualification for oral health practitioners, as are University of Essex. So these are people who can go out and work autonomously. I talked about a level 2 qualification just previously, so this is a postgraduate qualification of upskilled individuals, both at hygienists and therapists and dentists. So we can move these into primary care, and their main role will be to actually have the undergraduates being taught in primary care as well as the postgraduates, which will allow us to then increase the number of people working out in primary care. And the very good news is there's a recent report by NHS England referring to provisional registration, which allows overseas graduates to come and work in primary care as well. And that's something that we're also currently working on, so that we can increase the numbers of whole-time equivalents working across the ICB. Thanks, Peter. Yeah. So we've got, there's a range of professionals. I mean, I'll not necessarily go into each one of these, but as I say, we've got across the range a number of people from the normal staff in a dental practice, the hygienists, the nurses, the receptionists, who can then upskilling to extended duties nurses, who can then move on to hygiene, then move on to therapy, then move on to an advanced clinical practitioner, And actually there's work currently undergoing at University of Liverpool which allows some of their therapists then to upskill to dental training as well. So there's an awful lot going forward that will allow us to deliver this care in a more cohesive, joined up approach where the right treatment is provided by the right person to the right patient at the right time. And that's really what we want to achieve.
Thanks. So just moving on to some of our improving access actions. This next slide really summarises the most substantial difference that we're making immediately with regards to improving dental access. And one of the massive deterrents that we heard previously about the current contract is that if a patient is of a more complex presentation and is going to take longer to take care of for their health check or their treatment, the UDA system doesn't reward practices for the work that's involved with that. And so we are using the powers of flexible commissioning that enables us to pass additional funds or give greater flexibility for practices to earn their contracts by looking after priority groups. And so we've specified on the right the population who fall into this category. So we're really looking to improve our access by starting with the patients with greatest risk and greatest opportunity to benefit from the right-hand side. We have put this offer out to every practice in SNE, and so far we have got 20 providers who've taken us up on that, and that will mean that we'll be spending £1.5 million with those providers to provide extra services for these residents. This includes opening on evenings, weekends and bank holidays as a way to tap into the additional clinical hours to provide extra services. And so just to give you a sense of the numbers, that will be 230 hours per week of service that is starting in April, and in Nick's practice they've gone live already offering services to these patients. So when someone phones 111 with a really urgent need, the 111 have got a network of providers that they can then direct people to with these high priority needs as our first action that we're really pleased to be taking. We're also looking to make sure that we're asking each one of these practices to take specific responsibility for residential institutions. So we're trying to get to a situation where every care home and every children's home has a dental provider that they can look to say that is their ongoing point of contact for the oral health of their residents. And we have about a third of our care homes will be covered by the end of April once these 20 providers have gone live. We've got and this is a feature of SNE's dental services. We've got differential take-up across our area geographically. So we've got good take-up in Ipswich and Colchester, and we've got a lot of work to do in the Bury St Edmunds area to increase NHS dental provision. There's lots of other nuances, including Felixstowe and other areas where we've got geographical deficits, which I'll come on to in a moment. But there's a lot of important progress that we're making here. The next slide, and again this is one slide summarising a huge amount of work that sits behind this. We're going to be, we've already increased the minimum price for the unit dental activity, so the range of prices was enormous, and ahead of the national announcement we moved practices to just under £30 per UDA from what some of them are on £23, £24 to try to retain them, to stop them handing their contracts back, and to give them appropriate financial reward for the work that they're undertaking. We're developing new recruitment incentives to put out to help in line with the national offer to recruit. So it says September 24, but we'll be bringing that forward. And we've got, on the right-hand side, we've done provide an estimate of the amount of activity that we're looking to increase each year. So we're trying to achieve roughly a 10% growth in dental activity over the next 3 years, and that will get us back to fully deploying every NHS pound in the NHS dental market. It's a really ambitious plan that we're setting ourselves, and we can see the range of actions that help us to get there. And whilst we're using units of dental activity as a method of counting, that isn't how we're contracting for all the reasons that we've described before. A key opportunity that we're going to be taking advantage of is around 10 of our contract holders account for 80% of our underspending and underperformance. And so we'll be in contact with those contract holders to agree with them a realistic activity plan. And then we hope using new powers to bring that budget back to us, that we can then fund long-term procurements to bring in new NHS dental providers into the market, which will be a mixture of 5-day procurements and 7-day procurements, depending on the pattern of need. And one of our priority actions on top of the priority access service is to complete a needs assessment so we can be really clear, we know which geographical areas are the right ones to start in terms of going out to the market to recruit additional providers. We also have the Suffolk Dental CIC, which is opened in March, and it already has a training purpose, and it will be gradually recruiting its staff and will be a key component to also providing additional sessions in this context. Conscious of time, we've got a number of orthodontic providers, and generally the good thing about orthodontics is that the contracts are being fulfilled. So where we are offering units of activity for orthodontics, providers are completing it. But as a result of COVID and demand, we do have waiting lists. And so we are learning from Herts and West Essex colleagues who've commissioned a health needs assessment to work out our approach to this, so that we can make sure that there's covering Suffolk, and this is a long-standing service providing services for people with a learning disability and other needs, and we're working with them to increase their service provision and renewing contracts and introducing additional elements to their contracts to look to increase our capacity in this service. We've touched on secondary care. We've held a couple of workshops with the oral maxillofacial consultants in Norfolk and Norwich, and MSE Trust and Adam Brooks Trust, to working with SNF colleagues to say, so where might we go next to try to address the SNF consultant gap? And Nick started to describe the model that we're looking to try to achieve, which would be for Norfolk and Norwich to be able to recruit consultants who would cover the Suffolk population, operating out of SNF sites, depending on the nature of the activity, and then working similarly with MSE to recruit consultants. And that has the benefit of helping our population access services, but also helping the consultant rota to be workable for the NNN and MSE, where they're trying to get to 8 consultants on the rota for on-call, which will help, we hope, with their recruitment. But it's a really significant challenge in terms of attracting people to the area. Paediatrics is a national challenge, and I've already talked about the additional prevention work we're doing, and one of the ways we're getting into this is to there's be a set of national standards for paediatric practices and child-friendly surgeries in order for us to make sure that it's really important that children feel able to and can access services across our whole geography, and we know that we've got aspects of our geographical area where that isn't the case. I think I've covered off most of these areas. I think the other thing I just haven't spoken to so far is that we've got we're analysing our activity on sort of super neighbourhoods, so to speak, to work out, so what is the coverage across Ipswich, across Colchester, across certain of our patches, to help us work out which the geographical areas where we need to work. And also, if we've got, say in Haverhill, we're fortunate to have 3 NHS dental practices, and there's a range of care home support to try to bring those dental practices together to think, well, how can they work in tandem with each other? Because a bit like general practice 3 or 4 years ago, there's not great joint working between dentists at the moment, so we can hope to get the dentists to work in partnership where they are offering NHS contracts to meet the need. At this point, perhaps if I just give our final slide, then I'll hand over to our Healthwatch colleagues, if that's okay. Just in terms of the next steps for our plan, perhaps just one more slide on. Oh, sorry. So if the board, we're really looking forward to the board's comments on the plan today. We've raised with our county councils the question of fluoridisation, which has been raised nationally as a potential prevention tool, which is open to our councils and working on a regional basis to take that forward. And we are really interested in people's comments on this plan to help us develop it. And my proposal to you is to come back every 4 months with a really practical description of how we've progressed against this plan going forward. But perhaps if I stop there, consciously talked a lot, and then hand over to our Healthwatch colleagues for the Health Watch comment.
Peter, Nick, thank you very much. So, Sam, Andy, did you want to come in with some comments before we open up for questions? Yeah. Do you want to grab a mic, Sam?
Although you're all used to me shouting across the piece, and you're probably used to the fact that oral health prevention, promotion and education is my favourite topic. So dentistry and access to dentistry has been one of the main reasons why people contact us for as long as I've been involved in Health Watch. And I suppose there's this reform, but there's also making oral health everybody's business. What is good for oral health is good for health generally. We have a whole wealth of professionals who are talking to individuals, especially those individuals most impacted by health inequalities. So we can make this everybody's business. We can prevent a huge amount of dental disease and decay by working together on this agenda. We have done specific work around the special care dental services in the past, and there's some huge learnings from that we're able to feed forward into these plans. And I've worked closely with Nick in the past to share this learning. And I look forward to being able to share the learning in the West Essex and Hertfordshire area about the orthodontic services as well. We continue to be involved as much as we can because we know this is a priority area. And Nick very clearly outlined the impacts this can have on wider physical health from a physiological perspective, but there's also a huge biosocial perspective to this as well. We're going to be doing some work with our young people over the coming year because the massive impact on self-esteem, self-worth, perception, when you have poor oral health or poor dental health, when everybody they see on TV has great big white straight teeth, the impact that has on your smile, on your ability to chew, socialising, eating out, going for job interviews is huge. So we can really work on this as our whole system and I think make some huge improvements. Thank you.
Sam, that's great. Thank you. Andy, did you want to add anything? You're welcome, yeah.
I wish I could speak as well as Sam on dental care, the way she has just done just this minute. But if I could read out something, it's much easier for me. First and foremost, a thought on the National Recovery Plan. And by the way, we're so lucky to have Nick Barker here in the system, and we need to lean on you as much as we can, if at all possible. And thank you, Peter, for the work that your team's done. The Health Watch view on the National Recovery Plan is that it doesn't do anything near enough. Health Watch England spoke at the recent Health and Social Care Committee, which Nick referred to earlier, and its advice, gleaned from local Health Watch from across England, included the belief that, quote, the National Recovery Plan should have required dentists to put a digital flag on the NHS website listings to indicate to the public, and in quotes, I am open to seeing new NHS patients who haven't been seen in the last 2 years. So maybe that's something we can consider locally. The ICBs were given a broken system to manage, and the national reform isn't targeting the heart of the problem, which is the contract framework and the priority need to reform it. Again, Nick has spoken really well about that. We do, however, recognise that Suffolk and North East Essex's ICB has approached the challenge innovatively and proactively. The ICB is using its resources as wisely as it can, involving its key stakeholders, including both Health Watch, as Peter's described. We believe the University Dental Kick is, for example, local strategy and the action plans as described today will tell us how strong they are. And as a local Health Watch, both Essex and Suffolk were best placed to help SNE to independently recognise this, its gains and also anything it misses. About a year ago we did a study which is still relevant, and we received 180 comments. 157 said directly, 157 spoke directly about related problems with access to treatment or checkups. 46 referred to having contacted many practices without any success. and 22 parents, carers and guardians who had struggled to find dental care for their children. There was also an issue around accessing care for severe pain and discomfort. And I know 111 is there to support as much as it can. It has been referred to today, and it's not in their remit to make things better. But people end up going around in circles if they do contact 111, and they're advised to contact a certain practice, and that practice says no. Lastly, I would just say people still are told about being registered or not registered by dental practices at times. And I think language really doesn't help, because that went out back in 2006. So we need to really, really think about how we communicate well. And if at all possible, if we're going to evaluate anything that we're setting out to do, or we've already set out to do, consider doing it independently. You've got both Health Watch here prepared to do that if we can. Thank you.
Sam, Andy, thank you very much for those really helpful and supportive comments on what is, I think we all recognise, a really important work in progress. So let me open up for the board discussion now, but I'm going to start with Simon. If I come to you for Mr. Dooley's question on this particular item, and then I'm going to go to Ed, who has the answer to it, or to answer it anyway. Simon, over to you.
Thank you very much indeed, Will. So the question for Mr. Dooley is, how many patients in Suffolk and North East Essex have no access to an NHS dental practice?
Over to you, Ed.
Well, I think we had that data from Peter, didn't we? So I think, Peter, you referenced that in October 2023, our most recent data, 42.3% of the population in SNE had access to an NHS dentist. I think that's... So it's a sort of 60-40 situation.
Yeah. Okay, thank you. I've now got Frida and then Lisa. So over to you, Frida.
Yeah, thank you very much. Such an important... I always tell my children, teeth are your most important thing. You know, you need a good smile. And I think it's really important. But also as a GP, oral health is just vital to us. You know, you do everything for the patient, and you look at their mouth, and it's just wonder why they haven't been to a dentist. But my question is, there is a lot of parallels in terms of dentistry, dental contracts and general practice contracts, and the impact upon those contracts upon the workforce. What my question really is when you talk about introducing different types of dental technicians, if you like, in order to increase your capacity, they're not necessarily, whilst they're valuable, like we have an MDT team essentially, they're not dentists. And there currently is a massive debate in general practice and in secondary care as well regarding physicians associates, which I'm sure you've come across. And my question is, when you introduce this alternative kind of approach into the speciality, whilst it's really important, it's not a replacement for dentists. And if you're going to put that into NHS contracts, also the other thing, the side of it is you've got a large number of dentists now who are privately, like in private practice. How are you going to attract them into the NHS world when it's only £30 a UDA, which is not a lot compared to what they're earning in the private sector, I should imagine. And so you've got them stuck in the private sector. They've got no interest, like some of my dental friends have no interest in going back into NHS contracts. So, and this won't appeal to them. So then you introduce another workforce, which is a technician workforce. So does that not lead to an inequity of service delivery? Because in the NHS, you're going to have a workforce that is a replacement, essentially, for the dentists who are now stuck in or choosing to be largely in the private sector. And this is a problem we're going to see in general practice come the future as well, is that GPs are going to be diminished in number and are being diminished in number, and you're going to replace them with an MDT team of nurse practitioners, physician associates, etc. But you're not going to have your GP workforce. So you're going to allow for the NHS, which is serving the lower socio-economic in dental terms in this country, to perhaps a lesser specialty. I'm just saying that is a risk that they're not going to be served by dentists, where people that can afford dental care and go privately will have the dentists. So how do you kind of manage that inequity that is inevitable, really, in the model that you've described?
Go on, Nick.
I thought it might be best that I answer that one. It's a very good question. I think, first of all, in dentistry terms, we're, if I may say so, several years behind our medical colleagues, and that's some of the issue, and we can learn from our medical colleagues as well. In dentistry terms, it has been centred primarily, almost solely, on the dentist and not using these other dental care professionals. One of the key elements we're going to need to look at is reviewing a service evaluation, getting the data in and just seeing what happens, both qualitatively and quantitatively, as to how exactly everybody manages this sort of programme. I agree there's a risk that you may dilute the effects of dentistry rather than expand it by using these professionals, but there's a few points that would say that it could work. First of all, in 2011, we brought in dental pilots under an alternative scheme, which much more emphasised the prevention and the DCP-driven approach, and they were very well received by the dental profession. So I think we've learnt from that, first of all. The second element, I would say, is that by using these DCPs, what it does is it diversifies across a group, so that each of the dental care groups will work at the top of their scope of practice. So a dentist can concentrate on the more complex treatment, the more complex treatment planning, and then treatment plan out to these dental. Something really worthwhile, and I enjoyed it, and my patients seemed to benefit from it, much rather than earning the money at the end of the day. And what we could have, if this works well, and we've got to prove that it works well, is we may well have something where the system is actually better working under the NHS than it is privately, where the DCP groups just aren't used privately. And I think it could turn the dial in the other direction and actually look better that way round, if we use it correctly, if we educate the workforce correctly, if we evaluate the workforce correctly, just to make sure that they are getting the best of care. And ultimately, the main sign of that is going to be measuring health outcomes. Do our patients get healthier? If they do, excellent. It can't be any worse than it is now, and arguably it's going to be a lot better. Proof is going to be in the pudding, in the eating.
Okay, thank you. And colleagues, this is really an important subject, of course, but just to note, we need to keep going at pace, otherwise you are eating into the break period that I know you all want at some point. Let me go to Lisa and then Andrew. Perhaps we'll try and deal with your points as one in answering terms. So you first,
okay,
Lisa.
Yeah. Okay, thank you. My point was on the oral health promotion piece of the strategy. So the one workforce that will touch most of the groups that you have talked about is the nursing workforce. And oral hygiene is a basic fundamental principle of nursing care. Practice and knowledge will be inconsistent, and I think the work that you're doing with the care homes is great. But I think if we want to go quicker and faster, we need to take advantage of the chief nurse system work that we've got. We've got a great new chair of the Social Care Nursing Advisory Council across Suffolk and North East Essex. We've got the CNO strategy that's about to be published nationally that has a prevention element to it, and I think is a real thing that the nursing workforce, family, so this will really be about our healthcare support workers right through to our most senior nurses being really real advocates, because I suspect nursing practice is based on comfort and hygiene rather than a good understanding of safety. And I think we really need to develop the knowledge, understanding and practice of nurses across healthcare and voluntary sector, and I think we've got a really good opportunity to do that.
I'm just tempted to thank you, Lisa, for that, and well articulated as well. I saw such agreeable and supportive nods from Peter and Nick. I'm just wondering if the answer to that is yes.
The answer is absolutely yes, and I'm also thinking of the care worker sector as well. I'm
Yeah.
thinking that, but so really look forward to working together on that. Thanks.
So we'll take that as agreed and supported, Lisa. Thank you. Andrew, over to you.
Thank you. I've got three comments or questions, and happy to take the responses offline if that'd be better for the timing of the meeting. But the first of them is, as you may be aware, Susanna Howard and I are working on a clinical strategy aligned to some of the work we're doing, moving care closer to home and into the community. And as part of that, I think it'd be really important that we link up the dental clinical strategy with the rest of the clinical strategy, because there are real parallels between primary dental and primary medical care, secondary dental care, and really interesting conversations have urgent and emergency care for patients with dental disorders as well. I think we could incorporate into that piece of strategy work. I don't think you're behind us in all respects in terms of doctors versus dentists. The work you've done in Tier 2 contracts and specialty care in the community, I think we can learn a lot from, and there's a useful conversation there for us to have about delivering specialist services outside of hospital settings. My second comment's on workforce, and you referenced bringing in international dental graduates, and I think there's potential for us to work together on that, aligned to the work we're doing with international medical and nursing graduates as well, particularly on cultural awareness and cultural sensitivity, and onboarding them in an effective way so we keep them in the NHS workforce rather than elsewhere. And my third point is just an offer to perhaps look at severe mental illness as a priority area as well. Patients with severe mental illness have appalling dental health, and as we know, there's a mortality gap of about 15 years in this group. So there's potentially some work we can do with the mental health providers. I can see Kath nodding as well, to really focus on that as a priority group. Thank you.
Again, I saw positive and supportive nods on Andrew's 3 points there, including from Kath, especially on the mental health point. I'm just in the interest of time, can we?
I think you're right. That's some really helpful offers to develop this
Yeah.
further, and that's really welcome. And I think the SMI suggestions are really helpful. Thank you.
So let's take that as positive and agreed, and discussion outside the meeting as necessary to take forward. Can I, though, Fanuel, I was going to come to you next, but let me just hold you for a moment. Amanda, you had your hand up, and if perhaps using the workforce point that Andrew made as a segue, over to you.
Thank you very much, Chair. So I have a comment, question and a offer, really. So first of all, I commend the plan. I think it's excellent, much needed. And as Peter knows, I'm having a lot of conversations and more with both universities, particularly around the workforce provision at the moment. So just listening to the plan this morning, I very much would like to work with you both on overlaying the workforce plan that I'm starting to develop across SNE, interlay it with your overall plan. I'm very keen, though, to understand how we can improve placement capacity, because I think that's an opportunity, perhaps, that we can look more to going forward. For example, we know Suffolk launched brilliant programmes this February, inundated with applications. We only took a small number, didn't we? So I'm sure we've got opportunity, but perhaps something we can take offline. But it's really how we can improve, expand that placement provision for the future workforce. Thank you.
And may I make another suggestion, Peter and Nick? Is that something that you could take offline with Amanda and perhaps bring back into the first update?
Yeah, absolutely. I think I'd add the NHS England WTE dimension to this as well, as commissioners of dental training, but really happy to look at that. And I think part of what we see as the Dental Development Centre's role is sort of leaders and guardian of that relationship with where are their placements going, and how can we use those dental centres to bring that network of surgeries around them to support more placements and their progression through the dental careers.
Go on, Nick.
May I very quickly? Yes, I think all excellent points. Lots of opportunity to work with medical professionals, training the trainer, etc. On the placement point, there's a key element, and this is maybe where the ICB need to feed up to the national team as well, in the tariff payments for undergraduates in dental terms. So I think that's something we can take offline as well.
Really helpful, thank you. So another offline action there, thanks. I'm going to go Fanuel, then Moira, and then
Less at the moment around health inequalities. I mean, Ed mentioned earlier some of the work around maternity, and I'm just wondering whether maybe there's an opportunity here to piggyback on, you know, some of the existing work, given that it's linking up with some of the communities that we talked about who are, you know, less represented in this.
Yeah, so we'll take that into the community's agenda and work piece. I think agreed. As far, yeah, I see Peter's nodding. Moira?
Thank you. Really welcome the report, and particularly welcome the delegation of commissioning to local systems, because I think it's absolutely critical to have a good understanding of the population. Particularly welcome focus on looked after children, people with learning disabilities and autism, and care homes. And again, offer is there very much to work with you about how we support care homes, and in particular how we support people with dementia who have particular challenges around oral health as their condition worsens. Which I think builds on Lisa's point, and I also agree about focus on people with severe mental illness, because I think we've heard at a previous meeting smoking rates are exceptionally high in population with severe mental illness, so they're at much greater risk of oral cancer, for example.
So thank you, Moira, for that. Another offer of help accepted and noted. Finally, Ed, over to you.
3 comments. I mean, firstly, really encouraging plan, so thank you. I'm really pleased to have the endorsement of the 2 health watchers, and both county councils have been fantastic in this space as well, in the prevention space already. My 2 comments is, one, I think we just absolutely need to commit to commission for prevention. So, you know, as Nick described, kind of at the heart of this is the kind of the existing contract and the UDAs. I think, like we've done with the CIC, we should be commissioning for sessions where we can do, so people have more time to do preventative work, and use the flexibilities which you've already demonstrated. I think the thing that's missing for me at the moment is just the trajectory that comes out of this. So we've described a number of inputs. So coming back to the percentage we quoted back to Mr. Dooley, what's the trajectory of increasing that percentage of people accessing NHS dentistry and SNE as a result of the interventions you described? I know it's not an exact science, but I just want to get a sense of the kind of the next 2-3 years.
Yeah, well, so yeah, thanks, Ed. We've had a go at doing that in that table measuring units of dental activity, and if we were able to deliver that 30% increase, that takes us up to about 55-ish percentage. There are so many variables, so I think it's...
And that'd be roughly pre-pandemic levels, or a little thereabouts.
Yes, exactly. And I think I think that in terms of how we measure our success, I think we need to get better at getting more responsive health needs assessment data. I think it's really difficult to get a good data set that can track this. So that's one of the things we're wanting to do with our clinical fellows, is to get a really live data set. I think knowing the number of environments in which we've got care homes, a number of care homes, for example, or children's homes, where we're achieving a high standard of preventative behaviour, and we've trained all the trainers, that would be something we can measure, and I appreciate that's an input rather than an output. I think we also need to make sure that there's a minimum level of service that is available to all of our geographical communities, because there is massive disparity depending on where you live. And we should also be able to measure from the 111 service who's coming through, and because that, when the service isn't working, that will give us a really live report on how we're progressing. So I think we'll bring some measures as best we can, and I think we need to work with our dental and public health advisors to try to get the best data set that's in front of us. But hopefully that gives you a sense of the sort of proportion. And I guess just a word of caution, so this remains commissioned as a mixed model in the NHS, which is why I put the fees stuff up earlier on. We're not, England doesn't run 100% NHS dental service, so if we get up to 55-60%, then we should be working well, and we need to make sure those resources are most available in the more deprived communities, and we've really can be clear that those in that list we've identified, that those populations, we can survey them and say, can you access NHS dental? And that's how we'll know if we're succeeding, as well as the information on all different health outcomes.
Thank you, Peter, and I know the board will support your focus on inequalities and deprivation there. And final comment from Nick.
Thanks very much, Chair. Yes, the other point is determining what dental access is, because historically it's about going into a dentist. How about now we've got so many partners saying, well, access can be by just passing the dental knowledge across. And I think that's another key element that we need is access is when you go into geriatric services, into care homes, into maternity wards, etc.
Lovely, thank you. So, colleagues, that was a really great presentation. Thank you, Peter and Nick, and great input and support. Andy, from yourself and Sam for Healthwatch, Suffolk and Healthwatch, Essex, much appreciated. Good debate, great support, I think, from board in general, collectively, and a number of offers for future work and assistance and contribution into developing this programme of work. So thank you all for that. We've got 2 recommendations before us. The first one is to endorse the strategic priority in the 9-point programme. Are we happy to endorse, support, approve that recommendation? Done. And the second one is the recommendation that we receive regular updates, as we've discussed today. And the suggestion is every 4 months, so 3 times per year. Is everybody content with that? It doesn't stop you coming back with an urgent update, of course, Peter. Agreed? Done. Thank you very much. Thank you, Peter. Thank you, Nick. Okay, let's move on, colleagues, to item 8, the GP wellbeing item. And Andrew, I'm coming to you for this one.
Thank you, Chair. So, in 2020, on the 22nd of January 2020, Paolo Doria died by suicide. He was a GP that worked in Essex. There's a misprint in the cover sheet saying he worked in Suffolk, and I apologise, Frida, for that. And on the 11th of May 2023, so last year, Matt Maley, who was a GP actually working in Norfolk, but with a long history of working in Suffolk, also died by suicide. And in both those deaths, work stress was felt to be relevant in their illness and their death. And other staff are at risk of suicide as well, but there's considerable evidence to suggest that doctors, over and above all other clinical staff, are at higher risk of suicide, and within that group, GPs are at particular risk. A workshop was held last year now, some time ago now, and the paper in your of crisis in GPs, as in other clinical and healthcare staff. We've discussed this externally as well, and I've met with Dame Claire Gerada, who many of you will know as an ex-president of the College of General Practitioners, a highly distinguished GP and an international expert in well-being in the medical profession. And she really emphasised the value of listening to doctors, because we don't hold the answers at the moment in solving many of these problems. And part of the reason for bringing this paper to board today is to let you listen second or perhaps third hand, or maybe even first hand if there are comments, to the experiences of doctors and what might lead into these very tragic outcomes, which are albeit rare, but not rare enough. She was also very keen to work with us on developing solutions for risk in healthcare staff as well, which I think is something we should grasp with both hands. We already have many initiatives in this system trying to improve the well-being of all healthcare staff, including GPs, but almost all of these, if not all of them, I have to check the detail, but certainly the vast majority, are funded non-recurrently. And therefore they remain initiatives rather than the way we do things around here. And I wonder if that's something we want to consider. There's a particular emphasis in the feedback from GPs on the effect that complaints have on GPs. And I think GPs are in a different position to other healthcare staff with regard to complaints because of the way they're managed at the moment, and also because of the really quite extreme regulatory environment that complaints in primary care exposes those GPs to. There's certainly something we can do to think about the management of complaints in primary care. This paper doesn't come with any answers, and as I've said already, part of the reason for bringing it is to allow those voices to be heard by the people in the system that have the ability and the power and the leverage to actually make some change. But I also would like the board to comment on what they've read and to either challenge me or to offer potential solutions or areas that we should be exploring as a board to improve the situation, because 2 deaths by suicide in 3 years is too many, and a 3rd death by suicide from another member of the healthcare community is not something I want to expect. Thank you.
Okay, thank you, Andrew. And Andrew, just before I go to Simon for Mr. Dooley's question, which I'll do in a moment, you're asking the board to consider the actions it might take. Have you got a suggestion or suggestions you'd like to make?
So the primary care strategy already talks about the importance of safe working conditions for GPs, and that might be something that some of the attendees at the meeting here want to describe in a bit more detail. But I'd like us to think about that. I'd also like the board to consider how we might make the solutions we put in place, the wellbeing solutions in place, something more permanent than they are at the moment.
Okay, okay. I'm just going to, in which case, thank you for that. I'm just going to hold you, Simon, for a moment with Mr. Dooley's question. Let me go to Frida and then to Nick, and then I'll come to you, Simon. Frida?
Yeah, I just want to thank Andrew for bringing this to board. I'm really grateful. It's, I've been a GP for almost 30 years, and Paolo was a friend and a colleague, and he wasn't the first suicide I know. In total in my career, I've had 3 colleagues commit suicide, Paolo being the last, and all due down to stress, workload and complaints trigger. And the complaint system is, as you said, for all medical professionals, incredibly difficult. We're highly regulated, where we do feel that we're guilty before we're innocent in the regulation of complaints in medicine. I certainly was up against the GMC, and the whole process, whilst I was vindicated, took 6 months of my life and affected me deeply and my family deeply. It was an awful experience. I still get quite emotional about it now, and that was 10 years ago, and I don't think it's improved. And I think in terms of respect, GPs, I think it's about respect, and there's a lot of GP bashing that goes on as well. The complaints are just too easy. I deal as a senior partner with complaints regularly, daily, 1 to 2, perhaps 3, 4 a week, against all of us. And most of them I can bounce back, but some, I have to, address, and with my colleagues, and it hurts. It really hurts, and it's not just from patients; it's also from secondary care. I don't want to, but there's a lack of respect from secondary care for what GPs do, and I think that is something that is profoundly upsetting. Even when you ring up a secondary care colleague with a referral, you can be met with a disrespect. And that's incredibly hard. And so I think it's down to valuing GPs, valuing what we do, the pressures we're under, and showing some respect. And as Claire says, who I know vaguely, it is about managing the complaint system and making sure people are supported.
Okay, Frida, thank you. Nick?
Again, thank you for bringing this important issue to our attention. I mean, kind of we know anyway, but it's really helpful. I suppose for me, you're absolutely right that these initiative-itis around support is a bit unhelpful. But I'm also minded that as providers, we have very large, and we've invested over £1 million at ESNEFT in staff wellbeing. So we've got that infrastructure there, and I think it would be relatively straightforward to have a conversation about whether or not we commission that beyond ESNEFT employees and open that up to primary care. Because not just GPs, I think a lot of staff working in primary care now are feeling that stress and that pressure. So I think, given that everything from yoga through to intensive counselling and psychological and psychiatric input is available within ESNEFT, and I'm sure that I know that we could open that up. I think there's always particularly for doctors, and we know this from the acute, and I'm sure it's the same in all sectors. Some doctors find it more difficult to ask for help because of the nature of them having to cope and everything else. And there are issues around confidentiality, but I know, for example, our wellbeing staff see a huge number of medical staff, so I don't think it's insurpassable. So
Absolutely. Okay, thank you for that, Nick. I realise, Maddie, is your point on this subject? It is, in which case, go for it.
Thank you, and yes, thank you, Andrew, for bringing this, and also just for referencing the primary medical care strategy. So I just wanted to update the board that a draft strategy has been completed, working with the GP Collaborative. It's since been out for wider engagement, and thank you to everyone that has contributed to that. So we will now be incorporating that feedback, and that will come back to the board in the next couple of months as a draft strategy for overall approval. And that's very important because that's the broader framework and environment in which our GP colleagues are working, and that needs to complement the personal support that's offered to individuals. So that will return to the board. Thank you.
Thanks, Maddie. Thank you. Kath, again, quick question. Is it on this subject? It is, yeah. Okay, go for it.
Very quick. I just wanted to acknowledge what Frida said about the way in which sometimes GP primary care colleagues are treated by secondary care providers in their interactions, and would like to offer putting in contact with our Chief Medical Officer to be actively part of this. I think that we've all got a part to play in this, and I very personally can reflect on the impact on doing the day job has on our physical and mental well-being, and that affects many of us. But actually, as an isolated group of clinicians, primary care are very excluded, and I think we need to draw primary care in as not just as a mass, but actually a recognition of a large number of clinicians without whom the NHS would not be able to function, and we need to wrap around collectively. So I'd like to offer that support.
Thanks, Kath. Thank you. In which case, Simon, can I come to you for Mr. Dooley's second question, then I'll go to Ed.
And the second question is, what impact is envisaged by the employment of PAs in general practice instead of qualified GPs on the well-being of existing GPs?
Okay, all yours, Ed.
Well, I mean, firstly, physicians associates aren't substitutes for doctors. They're trained to work alongside. I think that's the key thing. So the intention is to, one of the outcomes would be to support the well-being and reduce the stress on GPs. But I don't know, Frida, you may employ PAs. I don't know whether you've got a perspective.
I don't at the moment, and the reason I don't, and we as a practice don't, is because we don't feel the regulation of PAs gives us enough security and confidence in their employment. To be honest with you, I do see them as working side by, or should, I do actually support the role of physician associates throughout the NHS. I just feel that they should be not a replacement, particularly for junior doctors, and they should work side by side with general practice, and that can be achievable. The trouble is with the capacity issue that we have in general practice, you do find PAs in some practices working with a perhaps a broader remit than they should be, and I think there is a real challenge with the safety and quality of that kind of approach, and I don't blame anyone for doing that because it's just a capacity issue. So I think in terms of PAs seeing undifferentiated work, that needs to be controlled better. But I do support PAs in general practice and the National Health Service as a whole, because I think they're important colleagues of ours, and I'm sure they will be very helpful and could be very helpful, but it needs to be monitored and regulated, and boundaries need to be drawn.
Okay, thank you. So, colleagues, and Andrew, thank you for bringing this subject. I think the board is supportive, recognise the points that are made around respect and mutual respect, both inside and outside of primary care, and the issues around complaint management, and agree with the points made. I think we're very grateful for the offers from Nick on behalf of ESNEFT and Kath on behalf of NSFT, if you like, for extending that support from your organisations out into primary care, and perhaps we could look for discussions outside of the meeting on how that might work. Thanks for agreeing to that. Yep, action there for both. Lovely. And then we are also supportive of the primary medical care strategy development and the engagement process that's now commencing, and ask that that does come back to board, Maddie, for the next meeting or the one after. Don't think we want this to go on for too long, do we? In the nicest possible way, let's make sure it stays current, as it were. Okay, so with that, Andrew, has that been helpful?
Thank you very much. Over and above the listening to these problems, there's been some really practical solutions, and what's been really rewarding is the willingness of the community to wrap around primary care and GPs and support them, recognising that without them, everybody else would fall over. So this is true integration in practice. Thank you.
Okay, lovely. Thank you very much. Thank you all. I'm going to move us on then to item 9. And we're rapidly getting to a position with no break if we're not careful. So what we'll try and do is get a break after 9, provided we don't overrun too fast. So, Kath, could I ask you to deliver the report from NSFT on behalf of Caroline, of course. Thank you for being here. Update us on the transformation journey.
Thank you. And I think there are some slides that's been provided as part of the pack, which I'm happy to have them.
They are in the pack.
They're in the
Put them
pack.
on the screen if you want.
I think if people want to take themselves through the slides, unless it's as easy, I'll just talk and hopefully the slides will keep up. So, firstly, thank you so much for welcoming this item on the agenda today. The Norfolk and Suffolk Foundation Trust, or NSFT, we know is on a very focused journey of transformation and improvement, and we continue to recognise that improvements in our care really genuinely are needed, and we do have improvement plans. Now, many of you will have met our new Chief Exec, Caroline Donovan, who does send her apologies today, and her real priority since arrival has been focused upon patient safety, and she's brought in colleagues to support this journey, recognising the need for significant support in this area. Oh, I think you wouldn't. Oh, there we are. Lovely. Sorry.
Well done.
Thank you. In the autumn of 2022. But a key area of focus for Caroline on her arrival has been a refresh and review of our trust strategic priorities, and our approach is that we will work together to provide safer, kinder, better care, but working in partnership with service users and carers, our partners and our staff. We have got 4 strategic priorities, which is improving health, improving care, improving value, and improving culture. Within this, we have 11 large-scale change programmes, and they are identified on the slide. That's just appeared. So you can see within improving health, it's about developing our strategy, learning from deaths, and addressing clinical transformation. Improving care is clearly about improving quality, but also ensuring that our leadership structure and the way in which we provide services is modern and fit for purpose. Improving culture includes being open and transparent and focusing on inclusion, and then improving value, which is essentially improving our governance, the introduction of a new electronic patient record, but actually making sure we get the best value for the money that is invested within mental health within our organisation. So you'll see within the pack some detailed updates which I clearly won't go through, but invite everybody to look if you haven't had a chance already. So I've already said we are focusing on holding ourselves to account for developing a safer, kinder and better organisation to make a positive difference to the communities that we serve across Norfolk and Suffolk. And our trust strategy will be the underpinning principle, which actually is being presented to our board later this week, and it will be supported by key enabling strategies such as people and culture, estates, finance, communication, engagement, that will be delivered through July and September this year. Learning from deaths is very much a priority, and you'll see on the slide relating to this, the priorities within this area include collecting, analysing and reporting on deaths, and we have introduced a new electronic system for collecting and reporting this, which went live in November. And in our board in public that takes place this week, the first 3 months of data will be presented to this meeting. We also, the focus not just on reporting and measuring, but also ensuring learning through improvements to clinical practice. So we're doing a retrospective review of all prevention of future death reports from 2013 in order to ensure that we have identified the themes and are ensuring learning and improvement has taken place and continues to take place. But also doing all of this in partnership with service users, carers and bereaved families. And we have people who have joined our Learning from Deaths Action Plan Management Group, very much listening to their views. And that is included in even how the information is presented in our report that's being taken to board this week. So it's about making sure it's meaningful but also sensitive. Clinical transformation. We have recognised the importance of addressing clinical transformation within our organisation, and to do so we are introducing a new role. So a Chief Transformation Officer, which is currently being recruited, is being included as an additional member of our board, and we have somebody in an acting role, which Sarah Cornick, consultant psychiatrist from Suffolk, who is in that role currently, and it's very much about clinical leadership and clinical transformation. Within the pack, I won't go through them, but you'll see metrics regarding performance and how, where possible, we compare to national standard. And you can see that there are areas of good practice, although recognising that continued improvement, strive for improvement, but also where we have need for providing better services. In terms of improving care, as the second of the strategic priorities, clearly improving quality is absolutely key. All of our must-dos, which are the requirements set out in the most recent CQC inspection report, are on track to deliver by June 2024. And I think the thing I'd like to share is, in order to determine that we have achieved the must-dos, we don't just self-manage and self-assess, but we took the learning from a trust in Norfolk about how all of the evidence to demonstrate achievement is scrutinised, and indeed we have external chairs sitting on that in order to provide that, not just scrutiny, but external assurance of progress. The EAG also includes other stakeholders, including service users, ICBs and Healthwatch, Norfolk and Suffolk. I mentioned about having a fit-for-purpose structure earlier. We are in the process of just about to commence a reorganisation across the trust, moving from 8 care groups to 5 place-based footprints. And you can see from a Suffolk perspective or a SNE perspective, one will be East Suffolk and one will be West Suffolk. But a key part of this process is not just about how we divide services up, but also how we make sure they are clinically and professionally led, and making sure that we have services that are equitable across the organisation. We know we have got inconsistent and variable models of care, some of which is really quite historical. So a big focus of this reorganisation is about addressing unwarranted clinical variation and making sure we have strong leadership within each of these new care groups to be able to deliver that. Improving culture, massive importance. We know the staff tell us through our staff survey. We see evidence within the RES reports, which is the racial workforce race equality scheme, where we have significant variation from many other trusts across the country, including mental health trusts, and that there is a long way to go. And our transformation is predicated on that being supporting our staff to be able to do their job and feel safe to do so. And actually, we want our staff to really feel like coming to work and serving the community of Norfolk and Suffolk is a privilege, but it shouldn't be so hard to do their job. Listening into Action is a national programme that Caroline, our Chief Exec, has brought into the organisation, which we've launched. It's a large change improvement programme to address organisational culture and enable staff to deliver excellent care. And we did a pulse survey check back organisation, identifying areas for improvement and empowering and enabling our colleagues across the organisation to take that forward. Being open and transparent, we know as an organisation, is an area of where we haven't done a good enough job historically. This isn't just within the organisation, but external to the organisation, how we are working in partnership openly and transparently with our system partners, including all of those sat around the table today. So from an internal perspective, we know we've already done a lot of work in relation to freedom to speak up and really strongly encouraging and empowering people to speak up. But the important thing is that we continue to act at pace on what people are telling us. But it is also about how we communicate within our organisation to our colleagues across the Trust. And this has been strengthened through communications leadership. And just want to take the opportunity to acknowledge and thank Nick from ESNEFT for the support of Rebecca Driver joining us for a year in NSFT, but also Norfolk and Waveney ICB with Paul Hemingway also come in. So having that system support in this area has been really welcomed and is paying dividends without question. But also the engagement and the communication from Chief Exec and the Chief Exec blog goes within the organisation every 2 weeks, but also the stakeholder communications that are taking place, I believe, are very well received. Inclusion. Oh, sorry. Inclusion. So we know, as I said earlier, race is a real problem within our organisation, and racist behaviours are really quite significant, and that's what's been reported through our staff survey. And there's real disparities. We know that there are areas we all need to improve. All of our colleagues across health and social care are experience racism, and it's unacceptable. But equally, what is absolutely within our gift is to make sure that we address inequalities that take place, such as disciplinaries for staff, shortlisting and appointments of people into roles. So we are commissioning an external review of race within our organisation, but also Caroline will be creating and chairing personally an inclusion council within the organisation. Done it again. And then finally, improving value. So our efficiency, value and improvement programme is something that's been introduced in the last 12 years. Now, one of our challenges is that we know without mitigation or plans to address, we have an underlying deficit within the Trust of around £17 million. That means we're spending more than we have, and we offset that through non-recurrent or short-term savings, and that, for example, might be to do with vacancies. And we don't want to be reliant on vacancies. We want to be able to be a sustainable organisation financially. And this is a problem that almost every organisation across the country experiences. But over the years, we have always managed our deficits through non-recurrent, non-transformative approaches. So we are really embarking on a efficiency, value and improvement programme, and recognising the challenges that we've had in previous years. We have brought in external interim support that has been commissioned to help us identify and have a real strong and sustainable focus on transformation and efficiency programmes. Governance is another area of strategic priority, and we have a corporate and clinical governance review underway, and that's due to be commissioned by the end of this month. But we're also focusing on our leadership in this area. We are in the process of recruiting a substantive chief medical officer, with the interviews taking place early April. In the meanwhile, we have got joint acting chief medical officers, Dr. Suhail Abrar, who's known to the Suffolk system, and Dr. Sarah Maxwell, who's more known in the children's world in Norfolk. They are appointed as joint acting chief medical officers for a period of up to 6 months. And we do look forward to strengthening our executive team with substantive chief nursing officer roles and the new chief transformation officer role that I mentioned earlier. And my last slide, Chair, is just acknowledgement of the electronic patient record as being one of our major change programmes. If you speak to most clinicians, if not all, that interface with Lorenzo, which is our EPR, they would express dissatisfaction and frustration with it. So actually having an electronic patient record that's fit for purpose and serves the needs of our colleagues and therefore our service users is critical to moving forward. And I'm really pleased that the outline business case for the EPR was agreed back in January, and we are anticipating approval from NHS England next month, and then we will start the commission procurement of a new electronic patient record, and doing so in partnership with all of the clinicians across the organisation is critical and reflective of the new culture that we are putting in place within the Trust. I'll stop there, Chair. I'm sorry if I've talked too long, but I'm very happy to take any questions.
Kath, thank you very much, and a very, very important item for us, of course, and thank you for that description of the journey that NSFT is on in so many respects, from leadership to culture to quality and delivery and so on. Simon, let me come to you first for Mr. Dooley's third question, and then I'll go to Ed to answer that.
Sure. The third question is, does what was presented by NSFT confirm on those past occasions when I asked whether Ed Garrett had confidence in the various leaderships of NSFT, to which he has always replied yes, that his replies were at best insincere to the detriment of service users and carers? In particular, I note the creation of a Learning from Deaths Action Plan management group, years after a solicitor with vast experience of coroners' courts, who offered to be part of such a group, was rejected by a previous CEO to contribute her knowledge for such a purpose. In my view, deaths may have been avoided. What's your view?
Thank you, Ed.
Thank you, Mr. Dooley. I think it'd be fair and factual to say that Caroline Donovan it's the first time in 10 years that we've had an experienced mental health chief executive at the helm at NSFT. She comes with a track record of turning around 2 other mental health trusts elsewhere in the country, and I think is the approach to learning from deaths and the new electronic system, which is now being, the data from which is now being presented to the NSFT board, which is good, and working through the other deaths between 2019 to 2023, and we'll have greater clarity there. So I think that would just be so important to have that clarity going forward, but also understanding what's gone on in the past. So I'm positive about Caroline's arrival and very supportive of her making improvements for the community. Thank you.
Thank you, Ed. Yes, Mr. Ducan. There's a microphone coming, Mr. Dean.
Thank you. I'd like to ask supplementary. You earlier on said that you would be meeting with the Toothless in Suffolk campaign to discuss the proposals around commissioning dentistry. Would you also consider meeting the campaign for better mental health services in Norfolk and Suffolk? And the reason I'm saying this is because I was privileged enough to go along to a meeting that they had arranged with the Clinical Commissioning, Care Quality Commission, sorry with all the words. It was staggering to listen to bereaved families talking about their experiences with NSFT, and I think you should meet with them to get a balanced view about what is the reality at the present time. And one of the things they referred to is the fact, given that Kath has just said that £17 million in deficit, that the NSFT spent £850,000 on a PR intervention, whereas you go to Helsden Hospital, see glossy this and glossy that and glossy the other. Underneath that are a lot of families who have been deprived of their family members through the failure of NSFT over the years. And for Ed to talk about Caroline being the first in 10 years, what does that tell us about the provision over the last 10 years? Thank you.
Thank you. Ed, would you like to respond to that?
Yeah, I have met campaign group members in the past. I'd be delighted to meet them again. So thank you for that suggestion.
Okay, thank you. Richard.
Thanks, Kath. So I'm fortunate to have heard this several times in other forums, so it's great to see that I think we've got a really clear strategy and a programme approach which we've not quite nailed before. I think it really aligns well to the Suffolk Mental Health Collab. So just for the board's reference, obviously we've got a delegated responsibility for mental health in Suffolk through myself into that board. And we considered this, I think, at the meeting before last and had an opportunity to comment through. I think Programme 3, obviously transformation, is the one probably I'm most interested in because it correlates well with the work that we're doing. And I look forward to the further report that Claire Holmes, I think, is nearly completed on looking at the Trust's approach to transformation and working with system partners. And I think clearly there's some improvement and more joint that we can do. And I also look forward to working with the new Chief Transformation Officer once appointed. I think it probably come not as a surprise to Kath that the area that I think we're most focused on and concerned about is children and young people's mental health, and that's come through strongly again in the work we've been doing through the collaborative as not where it needs to be, particularly with significant wait times to access support. And we've got a series of workshops underway across the system, particularly between the council and SFT ourselves, those with lived experience, to actually re-look at the whole model again. Because although clearly we need to improve wait times for access to mental health services under NSFT, I think we've got wider challenges on access and support to children much earlier in their pathway. So, Chair, I'll be bringing something through to the board specifically on that, hopefully in a couple of months' time. And then just more broadly, we're working closely with Norfolk and Waveney ICB as our neighbouring major commissioner for NSFT, because I do think there's more we can do better together. To reduce some of the burden on NSFT with reporting and with some of the governance side. So again, we'll be looking to bring something through in the future about how that will look. Thank you.
Great, Richard. Thank you for that. Kath, I'm sure that will be appreciated, especially simplicity in reporting where possible. So the intention's there.
Absolutely, and that helps set the scene, Chair, for if we work consistently with our partners, that also translates into consistent services that we provide across the two counties, which is absolutely critical for our population.
Yeah, okay, thank you very much. Susanna.
So thank you, Kath, for the update. And I think you probably agree that the thing that weaves all the way through everything you talked about is the need to improve culture. And also Richard's reference the issue about kind of working with partners in the system. We have been doing work in the system around how we improve culture, and in particular really leaning into that through truths, kind of really sitting about how through the lens perhaps in the past we have deep around some key issues. So one area depth absolutely acknowledge issues around kind of and so than that as well. I know that you're keen to make progress at pace. So I think the offer I'd like to make is to really kind of help engage NSFT with that learning that partners have contributed. A huge breadth of partners in the system have contributed around uncomfortable treatments.
Okay, really received.
Thank you, Chair, and thanks, Kath, for giving our scale. My I'm thinking about things like the level complaints, the staff experience, staff well-being, those feedbacks, some sort of short surveys, not waiting for the annual patient survey or staff survey. How are you going to get some assurance that this invested time is having impact to the people that matters most?
Do you want to deal with that one, Kath?
Yeah, absolutely. Thank you so much, Janet. Really important questions. So as part of our strategy, that includes the development of measures and metrics, not just at 5-year, but actually annually at least throughout the year, so we can measure improvement or identify where we're off track. So it is important that we don't just describe areas of improvement that we can't measure, although we do recognise that some stuff is a bit softer than that. But to want less complaints, because that could be reflective of people not feeling like they can, or what's the point of complaining. But it's actually what we do with the richness of the information that comes through the complaints and how that feeds into the themes and trends of our overall improvement programme. Because invariably, what comes through most complaints is going to be the same themes that have come from other sources, such as variation in clinical practice or staffing levels, or those sorts of things. So it is important how we learn from the information that's shared from complainants. And in terms of staff experience and wellbeing, it's really important. The annual staff survey has just been published. We can't wait another year to hear it back. So we have the pulse surveys that take place, which are the nationally supported pulse surveys that take place every quarter. So they give us an opportunity to hear from colleagues across the organisation. But again, there are other measures. So the listening to action was an additional way of identifying how people are feeling within the organisation and what needs to be improved. And they're within our gift to put in place in order to measure the effect of some of these programmes. And the other critical area, I think, which over the last about 16 months, since introducing a new Freedom to Speak Up service, new Freedom to Speak Up service, the level of people within the organisation escalating through the Guardian service has been of huge significance. And actually, again, staff feeling safe to do so is really important. And then where we are improving but still have work to go is what we do with that, the so what effect. So dealing with the issues that have come through on an individual basis, but also drawing in that thematic issue, because invariably there's some common themes that come through what staff are telling us. So it's measuring, but it's learning from what is being given to us. It's probably where we haven't done enough and done well enough in the past, but actually is critical to this overall improvement programme.
Thank you. And Janet, would it help if we perhaps suggested to the board and to Kath that we receive an update and impact progress report in, say, after the summer, in maybe the September board?
I think it would be helpful to see the impact.
Yeah?
Yeah.
Should we take that as agreed? Good. Thank you. In which case, Andrew.
Thank you. Just two thanks and an offer from me. So the first is I've really observed over the past 6 months a complete step change in the productivity, but also the insight into the work you've done around mortality. And I just wanted to give my personal thanks for that, because it's something I've invested a lot of time in as well, and I've really seen it start to bear fruit. And I think if anyone has read the board papers for next week, it's very obvious through that the work that you've done on that. So thank you on that. The second thing is to welcome the commitment to making your locality leadership structure clinically led. There's often a default when we say clinically led that people think that means doctors. With a nurse in the chief executive and the deputy chief executive role, I'm confident that you won't fall into that trap, and really keen to see how you develop leadership in the whole health and care community, professional community, to make those localities really effective. And the offer for me is just on inclusion and race. Ed referenced the workshop we did with colleagues from NHS earlier this month on cultural preferences, and if it would be useful, I'm happy to put you in touch with them, because I think the work they've done would have real impact in NSFT if you were interested in pursuing it.
Okay.
Thank you, Andrew. I just wanted to take the chance to say thank you to you personally as well for your support and contribution and leadership with the Learning from Death's work over the last 6 months or longer. I'm losing track of months. But it's really important that we, it's not just about how, as an organisation, we are tackling this, but how we're doing that in partnership with our system. Again, the learning together, but the transparency is absolutely critical. So thank you for your role in that.
Okay, thank you, Kath. So, Georgia, and I saw your hand up there, Peter, but then we must move on. Georgia?
Thank you very much, Chair. Thank you so much, Kath. That was really insightful. Two very quick questions from me. You described the system that went live to analyse and report on deaths. And I was just curious, at the moment you said it will report up to about October, is that right? Is there an intention that the system will be able to report live data? Is that, I'm just curious in terms of how, once it's up to speed, I imagine it's probably still playing catch up. I'm making an assumption.
Yeah, absolutely. So just to check, I heard you correctly, the learning from deaths.
Yes.
Yes, absolutely. So the system went live in November, and we reported the first 3 months. So and that's in our board this month. So there will always be learning. There will always be reporting in retrospect, but it won't just be what the data's telling us. Going forward, it will also be about the learning from the deaths that have taken place. So there will always be a period of time it takes to establish cause of death in the individuals that have passed away, and understanding how we would categorise them and identify what they're learning. And in some cases where there is further investigation that's needed, so it's not necessarily live. We will always know on a daily basis the number, but that's just a number.
Yes,
actually, it takes that longer time to understand the cause of death and understand, therefore, whether they were natural deaths that were expected, natural deaths that were unexpected, or whether they're unnatural deaths that need to be investigated further.
I understand. And is there a lag? I appreciate every person is an individual, so some people may take a bit longer. But from an organisational perspective, do you have an expectation in terms of how long that time should take for you to be just able to establish, to say, this is something we need to look further into?
So every day we get an upload in terms of the people who've died, so then it's about establishing the cause of death, which in some cases is more difficult to establish than others because we're reliant on external partners to provide that information. A clinical review takes place then in a matter of a couple of days, and that then determines whether or not that death needs to be investigated in a much more detailed way in terms of the National PSERF programme. So it's the complexity of everybody is very different, and also the information that's needed isn't always accessible. But what I would say is that we upload every single day to establish, whereas prior to this process we would review this monthly, and there would always be a data lag, and that was not acceptable. So it's a difficult question to answer, Georgia, because of the complexity, but we've put the mechanism in place now to be on top of this in a live way that
staff experiences, particularly around race. You know, in 2024, we know we can never completely, unfortunately, eradicate racism, but the fact that, you know, staff group is feeling in this way is quite sad. And it's an offer of support, really, from Suffolk County Council. I won't say we've got all the answers, but I think we're further down the journey than you are, and there may be things that we know work well and things that we know probably don't work so well. And also as an offer as a black woman myself with lived experience, so there's an offer of support.
Thank you so much. It's really helpful.
Thanks, Georgia. Finally, Peter.
Thanks. We had a meeting convened by the local MP with regards to Haverhill and mental health in Haverhill. And I just wanted to say thanks for we had 3 NSFT members of staff present, including one of the acting medical directors. And what became clear was the importance of, as I guess we all know, the relationships and connections that were being made. And the 2 opportunities we identified that in Haverhill we hadn't yet made the most of, and this may apply more broadly, was the links with the work coaches for DWP and the value for work for people's mental health, and the opportunity to support the voluntary sector to really being their coaches and sort of backroom support to help manage large quantities of mental health in the community. So, and I think that helps to emphasise that geographic approach that you're taking, and a sort of offer from us in the alliances to come alongside you in continuing to build all of those links.
Thank you. And sorry, just one of the real important feedback that we've received, and why we've taken the approach with that place-based reorganisation, is that we're too internal looking, and we haven't looked out, and we haven't sufficiently worked in partnership, and our service users, our patients, need that collaboration, and when we build the new structures within the new place-based care groups, one of the key priorities is about that external facing responsibilities and working with systems and working with partners, whereas it's been a bit of an add-on currently, and actually that's not good enough. So I think it's really important feedback that great we met with you, but so what? What's come as a result? And we haven't maximised that opportunity. So it is about, we recognise that, and we are substantiating the infrastructure to get that right. But in the meanwhile, I'll pick that specific up with you afterwards and look how we can improve that.
Kath, thank you very much. So, colleagues, we're asked to note, and if we're in agreement, to support the programme, the transformation programme as described, and the work in progress, and the continuing work which we've identified to be done. Everybody content to support? Lovely. Thanks very much. Okay, colleagues, what I suggest we do is take a 10-minute break. We're going to have to change our mindset, and after the break, accelerate, because we've got a hard finish time that we must achieve. So let's take a 10-minute break, and when we come back, we've got to take the papers as read and move promptly. So it is now 11:04, so 11:15 sharp restart. Thank you. Right, everybody, we're going to reconvene. Thank you very much for the morning thus far, which has been an expansive and deep and diligent discussion. We are now into some relatively operational as well as strategic, of course, but operational decisions. Richard, I'm going to come to you for delegation of specialised commissioning services to the ICB. Will you kindly take it as read, given that we've talked about this many times, and be as brief as you can?
I will always be brief for you, Chair, and sorry this is the more operational items of the agenda, but I'll try and make it as exciting as we can. So from the 1st of April, we will be, hopefully subject to the board agreement today, taking the responsibility for 59 services that are under the banner of specialised commissioning that have traditionally over the last few years been commissioned directly by NHS England. You'll see in the covering paper, and apologies, there is a raft of appendices in the document, that we're effectively asking the board today to sign off the delegation agreement and the collaboration agreement. The delegation agreement is effectively a nationally constructed document that Ed will be asked to sign on behalf of the board to take on the responsibility, and the collaboration agreement is effectively the document that binds the 6 ICBs in the east of England together, and we will be commissioning specialised commissioning services, these 59, as a collective, a collaboration of the 6 ICBs. The covering paper takes you through a number of the elements of that. There is nothing flagging as red. We've been through this many times, and with Tom's help, particularly from a governance perspective, Tom has pored over those collaboration and delegation agreements with a fine-tooth comb, and we're comfortable to recommend to the board agreement on it. It would be remiss of me not to say there are clearly some risks inherent with it, and you'll see those listed towards the tail end of the main document. I might ask Howard, you may want to briefly comment on the finance side, because this is a sizable shift of financial responsibility, £197 million of commissioning responsibility. And then finally, just to be clear, that NHS England will still be providing the support, the commissioning team support for this, which will be hosted by Bedfordshire, Luton and Milton Keynes ICB. So they're taking a hosting responsibility on behalf of the 6. And at the moment, you've got myself, lucky me, who's going to be the designated Chief Officer for SpecCom, and I'll be sitting on the collaboration group effectively that'll be overseeing this and reporting through to the board as I need to.
Perfect, Richard, thank you. And also worth noting that certainly Fanwell and I, we went to a workshop run by a region, NHSE region, on this the other day. I'm not sure whether Jeff and Janet, you were also there as well, the other one. Great, so we've engaged in this a lot. Let me go first to Howard to comment on the £97 million, 59 services, etc. Howard?
Yeah, thank you, Chair. So it's £197 million.
Oh, 190, yes, sorry about that.
Well, it was 100 million, to be frank. Yeah, so those of you who've been around the NHS as long as I have will remember the coming out in cold sweats in PCT days when waiting for the specialist numbers to come through. So this does come with a risk, but I think it's worth flagging 2 key mitigations, particularly pertinent to 24-25. One is we do have a contingency in place that has been embedded as part of the delegation, but also the key risk area, that being high-cost drugs and devices, is not being delegated at this point. So it's thought of as a low financial risk for 24-25, but obviously we'll keep a watching eye on it as it develops over the coming years.
More to come, as it were. Yeah, okay, thank you. Nick?
So just to comment, I haven't read all the appendices. I haven't read the whole book, but I'll put it out there. I'm sure the rest of you had. Sorry about that. This is just so exciting. I don't normally get excited about commissioning and being a provider. Well, I kind of do, but only for about a week a year. But actually, this is the opportunities presented in terms of local decision making for local people by moving SpecCom into the ICB is I think one of, when we first started talking STP and ICB, I remember we were pushing quite hard on this 7 or 8 years ago, and I think to see this come to fruition is really exciting. Clearly there is some risk, but I think the opportunities of local decision making for local people far outweigh any risk. So really welcome this and I'm very happy to support it. Thank you.
Nick, thank you very much. So, noting that the board has engaged in this agenda, courtesy of Richard and colleagues, on multiple occasions before, noting the external engagement with NHS England region and so on, that independent board members have had. There are 6 recommendations, if I'm not mistaken. Yes, 6 recommendations, which I'm going to avoid for the interest of time reading out unless you want me to. Are you, as a board, content to accept the 6 recommendations en bloc? Agreed? So resolved. Thank you very much. Well done, Richard. In which case, Richard, I'm going to stick with you for the next item on strategic planning, annual refresh, JFP, and etc.
Thanks, Chair. So I know everyone loves the JFP and acronym, and I'm bringing it back already again for your pleasure. So this paper's in 2 parts. One is the JFP, so the Joint Forward Plan, which is our 5-year rolling, effectively operational plan as a board and an organisation. And the second, which Ed touched on in his opening remarks, is the annual planning round that we're in the thick of at the moment. So if I stick first with the Joint Forward Plan, this document has to be updated on an annual basis, so it's a rolling plan effectively. And as you'll see in the covering paper and the JFP, which came out as a second attachment from Tom, you'll see that given we only effectively signed this off in June, and we're in year 1, we're not even 1 year in line with the other 5 ICBs in East of England, we've done a light touch refresh this year because we're not really that far in to effectively delivering the commitments we only agreed last June. So you'll see in section those key indicators. So you'll recall that we had 7 key commitments and 21 indicators that we were focusing our effort and energy behind. We've tweaked the one for maternity, dementia, and a couple of others, and they're outlined in table 1 further down in the paper. In terms then of how we take this forward, you'll see under section 3 that in line with the national guidance, there's a series of steps we have to go through each year. So one of which is clearly bring it to the ICB board for ratification and then ensure it's published by the 31st of March. So subject to your agreement, we should be able to hit that deadline next week. In terms then of where else it's going to the ICP. Thanks, Susanna, for getting a slot on the 12th for information. And it's going through both the health and wellbeing boards. So we've already gone through Essex last week in draft form. Moira's nodding. And at Suffolk, we're going jointly with Norfolk and Waveney ICS in May. And Ewan's asked if we can go to his board, Craig, just so you're aware, to present in May. I'm happy to come, or one of my team, to any other partner boards or forums if they would like us to go through it. And then final thing on JFP, really importantly, is we will be doing a kind of a 1 year, what have we done? And that will be part of our annual report as an ICB board. So having more of a focus in the annual report, not that the finance section is not exciting and some of the other bits, but we're going to have a major focus on what have we done in terms of delivery of our plan. And then just to finish, the second part of the paper, which is fairly light at this point, and I'll explain why, is operational planning for 24-25. So we've had the draft guidance, but we've still not had at this stage the final guidance from National NHS England team. Having said that, as Ed alluded to, we've been working hard anyway in the background across the partnership against the draft guidance to pull our plan together across operational performance, finance, workforce, etc. And we've formed a internal group working with our partner organisations to pull that together. So we should be in a good place, as Ed alluded to, once the final planning guidance comes out. Thank you, Chair.
Richard, thank you. Any questions for Richard on this item? Otherwise, if there are none, we're asked to note, should we note it as only being just over 6 months old since last approval, Richard, and that has been a light refresh for 24-29. So with those comments noted by the board hereby resolves to approve the joint forward plan for 24-29. Agreed? Agreed, thank you very much. And then notes the process going forward for operational planning for 24-25. Looks forward to a further update, Richard. Thank you. Everybody content? Wonderful, thank you. In which case, Howard, I'm coming to you for items 12 and 13, and unless anybody disagrees, I'm going to ask Howard to run 12 and 13 as one item. So over to you, Howard.
Thank you, Chair. So item 12 is a verbal update on financial planning, and item 13 is just where we are with regards to 23-24. So I'll just start off with the verbal update on financial planning. So as a reminder to the board, as a system, we're monitored by NHS England against the 4 formal members of our ICS. That's the ICB, East of England Ambulance, ESNIFT and West Suffolk Foundation Trust. At present, we're working, as Richard just said, without national guidance, but we do have a set of key assumptions that have been set out by NHS England. And of course, you'd expect that there is a requirement that systems developed financial plans that live within available resources. SNE is committed to developing and delivering a credible, balanced financial plan for 24-25. We are also working within the context of a clear expectation of minimal to no workforce growth underpinned by expected improvements in productivity as the NHS continues to recover from COVID. Our last planning submission was on the 21st of March and the final submission is due on the 2nd of May. So obviously this update is draft, and unfortunately, Chair, we'll probably need to organise an extraordinary board at the end of April to get the approvals in time for the 2nd of May submission. As of the 21st of March, our system plan did not meet the requirements to spend within our resources. In fact, we posted a 27.5 million deficit made up as follows. The ICB presented a balanced plan, East of England Ambulance presented a balanced plan, ESNIFT presented a 5 million deficit plan, and West Suffolk presented a 22.5 million deficit plan. The average efficiencies target for our system is sat at around 3% or £69 million, although there is some way to go still in development of those plans, which currently sit at just under 70% identified. And our level of unmitigated risk stands at 28 million and is predominantly driven by planning assumptions for inflation, cost improvement plans and elective activity. Our expectation at this point is that ESNIF will work towards delivering a balanced financial plan, and we understand that West Suffolk are also working towards an 18 million deficit plan, and I believe that was approved at their board on Friday. I should point out that it's not likely or credible for West Suffolk to develop a break-even plan for 24-25, but we are in discussions as a system about how we can support them in developing a trajectory to get to a sustainable break-even position over the next 2 to 3 years. And finally, I'd like to provide a bit of wider context. There are some significant structural deficits in some of our neighbouring systems, most of which lie somewhere between 50 to 100 million pounds in deficit, and typically cost improvement plans as a benchmark in those areas are sat at around 5% versus the 3% that is in our system. We need to be mindful of the pressures those systems are under, and including the financial pressures that our local authorities are in. It's likely that decisions to rectify those positions could have an impact on services for our own local population. And that's something we're going to have to be mindful of over the coming year. And also, while it's encouraging that our position is better than the NHS average, I'd like to reassure the board and hope to take any questions on the plan before I move on to 23-24.
Any questions on the plan? Otherwise, we're asked to note and look forward to an extraordinary board towards the end of April. Ed?
It's just a comment. I mean, as you've said, Howard, this is an ongoing process, and we're, do everything we can to get to a balanced plan. I guess the next phase of this will be looking at the collaborative governance and vehicles that we have in the system. So, the acute collaboration, the mental health collaborative. What are the conversations now around collaborating to balance, if I can put it that way? Whether it's, sharing resources, sensible efficiencies, economies that we could pursue. So I would hope that that's the next conversation we get into.
Yeah, I would completely agree with you, and obviously that's a position that NHSE have been taking as well.
Yeah, and nods of agreement from Craig and Nick, for which many thanks.
I didn't think there was an option, so I should
No, there isn't. No. Good point. Okay. Any other questions for Howard? Otherwise, received and noted, and look forward to the next update on in that extraordinary date TBA. I think, Tom, we need to sort. Yep. Okay.
Sorry, Chair, just a quick question, if I may. I think, Howard, you made a really important point there around some of the challenges the local authorities are facing financially. I'm just wondering where some of the impacts from a local authority perspective would be discussed in terms of the impact on the rest of the system. Is that here? Is that at the Finance Committee? Because there is that real risk, and it's something that we could, and I think unless we get, we could find some really innovative solutions to, which I've been discussing with Ed for a while now, and a few other people. So where would that get debated?
We've had some of those discussions in Finance Committee already, but I would agree with you, Nick. I don't think we've done it in a systemic way. We do have the Suffolk County Council Section 151 officer joining our exec committee. That's the ICB exec committee in the beginning of April, so perhaps we can discuss the next steps there.
Thanks, Howard. Quick comment from Georgia.
It's a good question, actually, Nick. So yes, agreed. Howard does have Section 151 officers meeting where that's discussed. At a more probably directorate operational level, we've got our healthcare strategic group where we've got leaders across health and social care. So that happens on a monthly basis, and we do pick up conversations there. But I think it's a good challenge because actually that's for adult social care. But it's not just when we talk about the council position, it's not just adult social care. It's about the other directors. So it's something to give a bit more thought to. Actually, that's a good question. Yes.
Okay, let's take that as something to work on, Howard. Yeah. Okay, Frida.
Yeah, just a really naive question. I'm sure everyone knows the answer to this except me. But how does, if the deficit of adjacent neighbouring systems rather, is like say 100 million, then how does that impact on our system, like specifically? What's the risk of that?
Well, I suppose the risk is where we've got joint commissioning arrangements on specific services that they are either starting to look at reducing or decommissioning altogether potentially to reduce their structural deficit.
So would that hit the specialist commissioning services?
That's one thing we need to start to understand, yeah.
Definitely work in progress, Frida. Okay, noted. Happy to move on. Back to you, Howard, for the update.
Yep, so that is a written report in the papers, which I'll take as read. I just want to pull out two key messages, really, Chair. So, first of all, at this point, I'm pleased to report that the ICS is on track to deliver a planned break-even position for the financial year. That includes a deficit of 6.3 million at West Suffolk, offset by surpluses in the other partners of the system, and it is encouraging that West Suffolk have delivered on their financial recovery plan this year after indicating they would go off plan back in May in 2023. So as I mentioned earlier, we'll continue to work with the Trust and across the system as a sustainable plan to come back to break even as developed. Secondly, I did report at the board last time that the ICS was likely to spend more than its allocation in capital on 24-25, which was due to a technical accounting change in how leases are reported. Capital and SNE system was disproportionately impacted due to the significant leased fleet of ambulances, and the provided allocation did not allow for that. I'm pleased to report that that matter has now been resolved for 23-24 via distribution of additional allocation, although we're still waiting for confirmation of what the resolution or the arrangements will be in 24-25. And finally, I would like to personally extend my thanks to Jeff Dobson and also to Joe Mail for their support in the development of the ICB Finance Committee over the last year. So I'm happy to take any questions. Thank you.
Thanks, Howard, and yes, thank you, Jeff, again. Any questions for Howard or colleagues So noting a forecast balance position at the moment for year end. Papers received and noted. Thank you very much. Item 14, the performance report, which is a chunky and often, I know, valuable report to board members. I wonder if we can go to any questions for team or team members, especially in Paul's absence here. Are there any? Ed?
It's more of an observation. As I said in my opening remarks, so far this month we've seen a real improvement in the emergency department, metric of the 76% from where we were previously. So I'm not entirely clear, other than the huge amount of planning and hard work that's gone in, what has delivered that significant step change, and it must be sustained post-March, it would be the kind of view. So it's just a worry that we deliver in March and then we fall back. So how do we avoid that?
How do we avoid that, Nick?
It's a very good point, Ed. It's a live conversation within Ipswich and Gloucester EDs at the moment. There is an element of running faster and jumping higher at the moment, so and more focus. But there's also a kind of parallel piece of work which is looking at the how we can sustain that improvement, but for Q1. We are hopeful that we will be in the top 10 providers, and therefore that will generate some additional capital, and we're looking at how we might probably more work to do in terms of flow internally, which is about, and I'm not talking about necessarily the classic kind of stranded patients. We're the 7th best in the country in terms of stranded patients. That's not a major challenge, but the simple discharges of Pathway Zero work and everything else is where we've seen success in other parts of the region, shall we say, more recently. So hoping to replicate some of that work, some of that learning. But it's a very, very live debate. I'm not going to kind of get to the 31st of March next weekend as the clocks spring forward and just relax. We're not kind of wired that way, as you know. So live debate, but we will come back if we need further system-wide support around that. Thank you.
So from a board point of view, we take that assurance that the focus is very much
the focus is very much on what happens, particularly in Q1, and then there's almost muscle memory starts to kick in then, isn't there?
Okay, happy with that, Ed? Well, yeah. Okay, Richard?
Just really quickly, I just want to flag cancer performance as well, which is in a great position comparably to where we were over summer. So a huge thank you to both trusts in terms of where we've got that to. And I think we're within, fingers crossed, everything crossed, we're within real distance now of hitting those key standards. So that's the 62 patients who've been waiting over 62 days for diagnosis. We're nearly there on, and secondly, on the 28-day faster diagnosis standard. So everything crossed that will hit that and then maintain it, as Ed just described, particularly to West Suffolk, who are, I think, got the second lowest backlog number and percentage now in region. So again, that's huge well done.
Yeah. Thank you, Richard. Any other points? I've just got one myself. I think, though, I'll ask for a written report on this one, Tom. There are 3 escalations in the performance report on page 286, escalations from the Quality Committee, which I think it's important that the board always note an escalation or escalations. Andrew, Lisa, could we ask for take an action to do a written report, a written note on an update on those escalations for the board in the interest of time? Yeah, thank you very much. Any other points otherwise received and noted? Thank you. Next item, Board Assurance Framework. Amanda, shall I come to you?
Thank you very much, Chair. So this is our updated framework for March. Since we last discussed as a board in January, no risks have been removed. However, we actually have added a new one, which is risk number 32, which is our children and young people services, which includes SEND. And this was added following the last board discussion, and it tries to show steps that we're now taking to address the risk in our ability to provide quality care to our young people in Suffolk and North East Essex, particularly in light of the challenges in Suffolk highlighted by the recent Ofsted and CQC report into SEND services. And after my update, Lisa may want to say a few more words. What I think would be important to acknowledge, Chair, is now that we're kind of getting a bit of a grip more into how we manage our risks. Each subcommittee that reports into the board has a standard agenda item pertaining to risk, and we're now getting into the flow accordingly. So at the last People Committee, we had a really helpful conversation into the current workforce associated risks. And from that discussion, there was commitment from board members or committee members to actually have further work and deep dive into the associated workforce risks so that we can mitigate and improve the position going forward. So that's very much work in progress, but encouraging at the same time. With regards to risk number 8, system adult mental health excluding dementia, following the last presentation in January, this risk has significantly been redrafted to shift the focus from the immediate issues facing adult mental health and focusing more on how we achieve the JFP accordingly. I think it should be noted that this revision of Risk 8 is still in draft, and we will continue to update and reflect in future iterations of the BAF going forward. So in addition to those risks, Chair, I think it's worth noting that during April, and in line with the system assurance framework conversations and work that we've done to date, Janet Wood, our audit chair, is actually going to be meeting with fellow audit chairs across the system to look at how we can link SAF into the BAF, and that'll be reported back at a future board meeting. So I'll leave it there, Chair, but I'm very happy for Lisa and indeed Richard to add to their risks accordingly. Thank you.
Amanda, thank you. Lisa, would you like to add anything there?
To be honest with you, I think the CYP and the mental health ones are fairly self-explanatory. The risks have been well articulated through the board previously, and I think this is our first attempt.
Area effectively, we've tried to narrow it down to some of those key areas that underpin the headline risk that you'll see described on page 333 in the pack. But as Lisa and Amanda have both said, for this and the mental health risk, they're both a work in progress with our leads, and Lisa and I are taking a joint lead on both of these because it crosses the commissioning and quality agenda.
Okay, Richard, thank you. So, colleagues, noting the addition of new risk 32, the work in progress around risk 8 and 12 and the system assurance framework, collegiate working, are we, and noting therefore, these are never jobs which are finished, are they? They're constantly under review. So with those comments and notes, are we happy to approve the BAF as of today? Approved? Lovely, thank you very much. Item 16, Susanna, over to you.
Okay, so this is an update from our Integrated Care Partnership. So I'm going to take the paper as read, including, for example, the update on our new co-chair, Councillor Rivet, and also the kind of overview of our last meeting of the ICP. I'm going to talk about 3 areas of work in the ICP in particular. The first is our ongoing system learning programme, which Ed referenced at the beginning of the meeting, Uncomfortable Truths. So we've now held the second of 3 meetings involving a very wide spectrum of partners around Uncomfortable Truths. The first of these meetings very much lent into the kind of why and really sat with the kind of discomfort around a number of difficult facts about health and care, which are kind of really indicators of long-standing systemic injustice in health and care. And in our second event, we really then lent into the issues about how, and focusing on not just kind of how we can make a difference, but also how perhaps in the past our efforts to change and address systemic injustice have not been potentially successful. We're going to be sharing the report from that second meeting to sit alongside the report of the first early next week. And that sets out a number of areas where we kind of agreed at the meeting, if you like, we need to take action. And those were through our everyday interactions as individuals, so by being better listeners, by building trusted relationships with people and communities, in our policies and practices, being better leaders, by assuring the quality of decisions we make, being more accountable, by leveraging our role as anchoring organisations, being community champions, by inspiring and influencing young people, and by continuing to pay attention to uncomfortable truths and continuing to be true allies. So those are all kind of key areas around uncomfortable truths. And of course, now we're moving on to the what. And that's where I very much hope, as an integrated care board, we can really kind of get behind each of those kind of key areas and think about how we can really kind of, shift our focus in terms of how we work as an NHS integrated care board. And looking at those actions, they actually resonate very, very clearly with the content of NHS England's new Director Competency Framework, which was shared in March 2024, following the Lucy Letby conviction and also the Messenger review, which were very much about culture in health and care. So looking at those areas, if you like, obviously we've got action in many of the areas there, but really the messages from Uncomfortable Truths are about really kind of, changing the way that we address some of them. So, for example, not just doing diversity and inclusion training, but as Andrew mentioned earlier on, and Ed referenced, for example, creating cultural safety, for example, just really shifts the dial a little bit on that, and, for example, promises a more powerful approach. So that's an update on Uncomfortable Truths. Ed also mentioned at the beginning of the meeting that we held a Thinking Differently Together event around growing up in care. And this was very much about listening and learning from the experience of people from the care system, very much people who have had personal experience of growing up in care, but also foster carers, the police and a number of other agencies shared their experiences as well. And I think the key messages from that were, I've summarised in kind of two sound bites. The first is good enough is not good enough, and that we really do need to go above and beyond. So again, we'll be writing up that event, sharing that report, but also looking for a further conversation now about how we can really go above and beyond on behalf of young people in the care system. Finally, around our ICS integrated care strategy, the Department of Health and Social Care have recently updated their guidance to integrated care systems on the preparation and onward development of integrated care strategies. And we're looking to kind of do a little bit of a refresh on our integrated care strategy by starting to incorporate some of the discussions that have been ongoing in the system around left shift. It's already come up in the meeting today, around some conversations that have been taking place at the Integrated Care Partnership Committee and other places around the importance of a left shift in health and care. So in true ICP style, we're looking to bring together a very broad range of partners to begin that conversation about the kind of, truly strategic, really, and about how we can, really further develop that vision around a future shift in health and care in Suffolk and North East Essex. And very excited to say that we're going to be inviting partners from our neighbouring systems as well to join us in that conversation, recognising the complexity of our footprint, but also looking to kind of, really leverage the learning and partnership and involvement from as many stakeholders as we can in that important conversation. So that, I think I'll leave there. Thank you.
Susanna, thank you very much. Some great work there. Any questions for Susanna? Otherwise, should we simply say, well done, received and noted, and look forward to the event on the 12th of April, which will be an important foundation stone, I think, for the future. Okay, in which case, item 17, you've got committee minutes and highlight reports before you. There are 6 of them. Let's see if we can take them on block. Are there any questions from any board member on any of those minutes or highlight reports? Otherwise, shall we say, I won't read them out. They're in the pack you've got. All 6 received and noted. Great, thank you. Item 18, the attendance log. Again, we only have to receive a note unless there are any questions. That takes us on to any other business. I've got the usual. So Clacton Town Hall. Yep, all booked. Look forward to it. Okay, in which case we're on to questions from the public, and let me look at Simon first to see if there are any, have any come through the live streaming, Simon?
No, nothing through the live streaming.
Okay, so colleagues with us today, I think Simon's going to deliver you a microphone, so if you'd like to introduce yourself and ask your question, and we'll figure out how to deal with it.
Hello, Mrs. Barbara Robinson, who has been working on service development for too long, 2 decades. I've got 2 questions. The first question is in regard to your financial planning and the pressures on you from local authorities and planning. This week I received a further iteration of a plan that's been kicking around now for the north of Ipswich for 11 years. It may have gone below the radar because the borough, Ipswich Borough, haven't actually issued this correctly, but I have forwarded it to the people in the ICB who will need to know. My question is, what is being proposed is not credible in terms of planning and services. So, will you ask your estates to have another look at their health impact assessment, which we forced on this specific application, which is for 1,000 homes, revisit it, update the amount that you require from the developer to deliver services, because at this point, the services aren't there and you're under pressure. So there needs to be a revisit of this. I'll send the details. It's the Garden Suburb, Red House Farm. There's another one next to it, which is another 1,000, and there's a further one adjacent to it, which is 1,200, which won't have come to you yet because it's in outline. But we're talking about 3,000 homes, which you need to comment and stake your claim for some money for the services that will be required. That's the question for that. The second question I have, if that's permitted, is can I ask a second separate question?
Keep going, yeah.
Would the board join me in thanking an exceptional officer who will be leaving soon, who has worked with us and co-produced with us for 20 years, John Reynolds. I brought a card of gratitude to him and for the work he's done. Maybe some of the people on the board don't know John because he's very discreet and unassuming. He's going to be sadly missed. And in terms of what he's done for us, I wouldn't be sitting here today banging on at you people to deliver what we have had offered to us if it weren't for John. And we are exceptionally lucky with your commissioning team. It's going to be depleted without him. So that was my second question. Thank you.
Barbara, thank you very much. Could I, before I come to you, Mike, Amanda, would it be appropriate for the board to ask you to pick up both those points that Barbara has raised and prepare and issue a written answer and response? Yeah, so we'll take that forward, both of those forward, Barbara, thank you. And then, Mike, did you have some? Yeah.
Good afternoon. It was almost worth getting out of my bed of pain to come and listen to how you're going to address the calamity that is inspected every child's teeth and then recommended what would be happening. That was normal. And here we are 65 years later with a calamitous situation, really. I was very impressed by your presentation, what you're trying to do. I was very keen to see that you're going to have some flexibility in it, because it was apparent back in 2006 that the new dental contract was a disaster waiting to happen, and sadly it has, and you've now been given the responsibility of picking it up. So I wish you well of that, and I will certainly note it. Felixstowe is a dental desert, even though it's on the coast, and hopefully things might be addressed there, and some of the dentists may be encouraged to come back and give more of their time to it. What I wanted to raise with you is a question from Roy Gray with regards to Felixstowe Community Hospital, but the one that I'm particularly concerned about is, I believe I shared with you some time ago the King's Fund report on driving better health outcomes through integrated care systems, and the roles of district councils in that, and that was over a year ago. But some of you may be aware of a very recent report by the King's Fund saying making care closer to home a reality, refocusing the system to primary and community care, and this was actually released on February the 24th, and it is a very I think important document with regards to advising integrated care boards on how they themselves could perhaps drive expenditure in the future to fund a greater proportion to go into community care. Looking at the charts they gave, 60% I think of face-to-face appointments are with GP of all NH works. I think if we look at the funding, it appears that primary care gets about 15 billion, and I think acute care gets 80. A considerable difference. And what this report says is the only way you're going to assist community care is if you were to do something drastic like closing a couple of acute hospitals. But they point out that we as a community, with comparable economies and nations, actually have much less hospital provision give a greater resource into community, because the actual proportion has been reducing and reducing and reducing. And I think acute hospitals can always make a very emotional case for better equipment, and that overrides allocation of funding to community. So I would hope possibly you could make this a particular subject for a forthcoming meeting, in that it is key to trying to improve community care, which would then reduce the demand on acute care. You'd actually have a far better outcome for health and well-being across our home community. And as the dental team pointed out, if one part of the system fails, it impacts on diabetes. A whole list of things were given to you this morning, and we're only as strong as the weakest part of the system, and it would appear currently the weakest part is community health.
Mike, I think that's really helpful. You are possibly preaching to the converted there as well,
Yeah.
in so many respects. Maddie, could I ask you to pick up the, not now, but the Felixstowe point specifically that Mike raises, and deal with that as a written answer? And Susanna, would it be fair to say that a number of the points that Mike's raising around the King's Fund report and so on will be dealt with, will be a considerable content of the Future Shift discussion, starting on that April the 12th event to which you referred in your presentation. Yeah, so thank you for that.
Could I just raise a question on behalf of Roy Gray, Chair of
Chair of the League of Friends of Felixstowe Community Hospital?
We were both very pleased to see that Clapton has now got a full diagnostic centre up and running, which will undoubtedly improve community care in that area. We were also delighted to see that Aldborough has actually has provided a considerable amount of funding and is having a new X-ray. We were appalled to see that the X-ray equipment in Felixstowe Hospital has been removed. We're also surprised that following a significant amount of fundraising in excess of £200,000, in discussions recently, it would appear that the building would require something like £80,000 to £90,000 extra to adapt the building to take the new equipment, assuming you were supportive of Felixstowe having an X-ray working again. Can you explain what is wrong with the Felixstowe fundraising compared to Aldborough? Thank you very much.
Okay, we'll deal with this in two parts, but again, Maddie, could I ask you after the meeting to specifically pick up, but I know Nick wants to come in here, so Nick, over to you.
As you know, this has been an ongoing conversation, an ongoing meeting for several years now, and I don't think it's appropriate to go into all the detail of this meeting. You know that we've had several meetings, you know there's another meeting, so it's not something we're not aware of, as you're well aware, and you are also well aware of the reasons for the current decision. So I don't think it's right to bring it here. Happy to catch up outside. Thank you. Thank you, Chair.
Okay, thank you. And Maddie, leave that with you from a formal response point of view as well. Thank you. Thank you very much. So, colleagues, it's 12:04. We are actually 9 minutes late, which is possibly a lot less late than we had thought at one stage. So well done for that. But I suggest that we close the meeting, and for those who are staying for the private and confidential part 2 meeting, we have a 5-minute break and reconvene. Thank you very much, everybody. Thank you.